Very good afternoon to all of you. Hope all of you are fine. Okay. Am I audible properly? Let's begin our chanting and rapid fire round quickly. And if you want to interact, you can interact. I'm with my phone and we will try to take maximum output of this session to score maximum marks in our exam. So let's begin with missed all-in-one chanting, and during this chanting process only, we will be doing interactive session with rapid fire. I'm with my phone. Quickly, I will try to see some messages also, and we won't waste single minute. And all those who are answering correct will get chocolates whenever we meet, whenever you are in Delhi, or whenever I am coming to your town. So let's begin quickly with all-in-one. Fine. So, sequence of events at puberty: increase in arm span, thelarchy, pubarchy, increase in height, menarche. Axillary hairs, they develop almost at the time of menarche or little before that. So, the correct sequence is increase in arm span, thelarchy, pubarchy, increase in height, and menarche. What is precocious puberty? If secondary sexual characters develop before 8 years of age. What is precocious menarche? If secondary sexual characters develop before 10 years of age. Cause of both precocious puberty and precocious menarche is idiopathic. Most common cause of precocious puberty is idiopathic. Most common cause of precocious puberty is idiopathic. It's idiopathic. Fine. And most treatment for precocious puberty and menarche is continuous GnRH. What is delayed puberty? Come on. What is delayed puberty? If secondary sexual characters don't develop even till 13 years of age. That's delayed puberty. What should be the management of? What should be the management of delayed puberty? Continuous GnRH or pulsatile GnRH? Continuous GnRH. So be very careful. Precocious puberty, precocious menarche, management is very good, very nice, very nice. Precocious puberty, precocious menarche, management is chocolate question on 12th of December. Precocious puberty, precocious menarche, management is continuous GnRH. Delayed puberty, management is pulsatile GnRH. Precocious puberty, if secondary sexual characters don't develop till. Don't develop. Precocious puberty, if secondary sexual characters develop before 8. Before 8 years. Precocious menarche, if menses begin before 10. Menses before 10, precocious menarche. Menses before 10. Menses before 10, precocious menarche. Secondary sexual characters before 8. Before 8, precocious puberty. Most common cause of both, idiopathic. Treatment of both, continuous GnRH. Delayed puberty, if secondary sexual characters don't develop even till 13. Very nice, very nice, very nice. Chocolate for you, whenever we meet. Fine. So delayed puberty, pulsatile GnRH. Fine, fine. Wow, 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 wow. Delayed puberty treatment, pulsatile. Delayed puberty treatment, pulsatile GnRH. Very nice. Number of oogonia are maximum at what time? 20 weeks. Number of oogonia maximum at 20 weeks. 7 million. Chocolate question. Important chocolate question. Number of oogonia are maximum at 20 weeks. 7 million. Number of oogonia at the time of birth. Total number of primary oocytes at the time of birth are 2 million. They are 2 million. Important question. Lifespan of oocyte and lifespan of sperm. Lifespan of oocyte 12 to 24. Lifespan of oocyte 12 to 24. Lifespan of sperm 48 to 72. Oocyte 12 to 24. Oocyte 12 to 24. Oocyte 12 to 24. Sperm 48 to 72. Sperm 48 to 72. Tell me how much is the rate of growth of follicle per day. Tell me. How much is the rate of growth of follicle per day? Rate of follicular growth per day. Follicular growth per day. Follicular growth per day. 2 mm. Size of dominant follicle. Size of dominant follicle. Yes, 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 yes. Very nice. Dominant follicle. 14 mm. 14 mm. Follicle ruptures at what size? Ruptures at what size? Chocolate for you. Follicle ruptures at what size? Wow! So many messages. So proud of my loving students. मेरे प्यारे प्यारे बच्चे are ready. Oh my God. Okay, so follicle rupture set 20, dominant follicle 14, rate of follicular growth 2 mm per day. Come on, speak out. How much estradiol required for LS surge? How much estradiol required for LS surge? 200 gram or nanogram or picogram? 200 picogram per ml, which should sustain for at least 48 hours. 48 hours. और कहाँ पड़ा था 48 hours? Where else 48 hours? 200 picogram per ml, which should sustain for 48 hours. Tell me, doubling time of HCG, 48 hours. Doubling time of HCG, 48 hours. Investigation of choice for ectopic pregnancy. TVS plus beta HCG correlation. We are doing beta HCG now and repeating after 48 hours. If beta HCG doubles, normal late intrauterine pregnancy. If beta HCG increase but does not double, ectopic pregnancy. If beta HCG falls after 48 hours, abortion. Very nice. Abortion. My God, मजा आ गया यार. Such an interactive session. If beta HCG falls after 48 hours, abortion. Doubles, normal late intrauterine pregnancy. Increase but does not double. Ectopic pregnancy. Fine. So how much estradiol is required for LS surge? 200 picogram per ml, which should sustain for 48 hours. For calculation of day of ovulation, what is subtracted from cycle length? Important chocolate question for 12th of December. Whatever stuff we are discussing, the stuff is for 12th of December FMG exam today. No wastage of single second. To calculate day of ovulation, very nice. Minus 14. Very good. To calculate day of ovulation, 50-day cycle, day of ovulation, 36. 50-day cycle, day of ovulation, 36. Done. Nicholas formula to calculate expected date of delivery. But this formula is for 28-day cycle. If cycle length is 30 days, what are you going to do with expected date of delivery? Come on everyone. If cycle length is 30 days, 12th December question. Nicholas formula for calculation of EDD is for 28-day cycle. If it is a 30-day cycle, add 2. 34-day cycle, add 6. 25-day cycle. If it is a 25-day cycle, subtract 3. मेरे बच्चे बिल्कुल गलती नहीं करेंगे. GTPAL scoring system. Gravida parity. She delivered triplets in last pregnancy. 12th December question. She delivered triplets in last pregnancy. 3 बच्चे पैदा हो गए last pregnancy. She is pregnant for second time. Tell me her gravida score. She is pregnant for second time. She delivered triplets in last pregnancy. Tell me. Wow! Gravida score. Very good. Shashti, Isha. Very nice. Priya. Very good. Very nice. Ronnie. Very nice. Elizabeth. Very good. Aruna. Superb. All these chocolates for you. I don't want to take names. I won't take, because otherwise most of the students, they will feel annoyed. I won't take names. Okay. Fine. So let's come back. So Nicholas formula, we are done. Gravida parity score, we are done. We will not commit any mistake in these traps. Trimester, first trimester, if up to 14 is given, that will be the best answer. MTP these days can be done up to how many weeks? 24. Last criteria up to 20 weeks. According to latest criteria up to 24. According to latest amendment of MTP Act, consent of 2 doctors is required consent of two doctors is required between how many weeks? Come on. Very nice, very nice, very nice, Swarna, very nice. Consent of two doctors. Sheikh, very good. Abhirami, very nice. Laksha, superb. Shrabani, superb. Anu, very nice. Consent of two doctors is required between. Consent of two doctors is required between 20 to 24. So be very careful. If MTP can be done is asked, it can be done up to how many weeks? 24. Tell me the suction pressure in suction evacuation. Suction pressure in suction evacuation. 400 to 600 millimeter of mercury. What is the best answer? The best answer is 600 millimeter of mercury. LH surge is attained how many hours before ovulation? LH surge, how many hours before ovulation? 32 to 36. The best answer is 36. LH peak, very good, very good, very good. LH peak is attained how many hours before ovulation? 10 to 12 hours before ovulation. Fine. Tell me the gold standard for ectopic pregnancy, yaar. Gold standard for ectopic pregnancy. What is the gold standard investigation for ectopic pregnancy? Come on, nobody answered yet. Gold standard investigation for ectopic pregnancy is laparoscopy. Wonderful. Investigation of choice for endometriosis, by the way. Investigation of choice for endometriosis, laparoscopy. Very nice. Laparoscopy. Superb, superb. Gold standard for adenomyosis. Gold standard for adenomyosis. Come on, everyone. Gold standard investigation for adenomyosis is hysteroscopic curettage. Investigation of choice for adenomyosis. Investigation of choice for adenomyosis is MRI. Investigation of choice for adenomyosis is MRI. Gold standard for uterine fibroid. Gold standard for uterine fibroid. Come on. Come on. MRI. MRI. 3 questions better for fibroid investigation. Gold standard for fibroid. MRI. Investigation of choice for fibroid. Ultrasound. Investigation of choice for follow-up of fibroid. Ultrasound. Gold standard investigation for diagnosis of congenital malformations of uterus. Gold standard investigation for diagnosis of congenital malformations of uterus. We are discussing 12 December stuff today. Gold standard investigation for diagnosis of congenital malformation of uterus. Laparoscopy plus hysteroscopy. Very good, very good. Combination of laparoscopy plus hysteroscopy. Tell me, I am asking this question, I am deviating this question, modifying this question. If laparoscopy plus hysteroscopy are not given in option, if laparoscopy plus hysteroscopy are not given in option, what will be the second best answer? Gold standard investigation for diagnosis of congenital malformation. Very nice. MRI. Very good. Third variant of this. Investigation of choice. Most commonly done investigation to diagnose congenital malformations of uterus. Most commonly done investigation to diagnose congenital malformations of uterus. Ultrasound. 3D TVR. If 4D is given, that will be the best answer. If 4D is given, that will be the best answer. Tell me. Investigation of choice for choriocarcinoma. Come on, गायनी से ऑप्स में पहुंच गए हम. Investigation of choice for choriocarcinoma. Choriocarcinoma. Investigation of choice. Tell me. Investigation of choice for choriocarcinoma is serum beta HCG estimation. Serum beta HCG estimation. Tell me the score of low risk choriocarcinoma. Score of low risk choriocarcinoma less than 6. If it is less than 6, low risk choriocarcinoma. High risk choriocarcinoma. Come on, everyone. High risk choriocarcinoma is if score is 7 or more than 7. Tell me the management of low risk choriocarcinoma. Management of low risk choriocarcinoma is methotrexate, single agent therapy. Methotrexate, single agent therapy. Tell me management of high risk choriocarcinoma. High risk choriocarcinoma, if score is 7 or more than 7, management is Bexoridine. Which Ridine? Bexoridine. What is Bexoridine? Immunotherapy. So high risk choriocarcinoma, Bexoridine, immunotherapy. Low risk choriocarcinoma, single agent methotrexate. By the way, what is the management regime of eclampsia? Management regime of eclampsia. Come on, everyone. Management regime for eclampsia, Pritchard regime. Management regime for eclampsia, Pritchard regime. Tell me management of mild PIH. Mild PIH management. A patient presents with mild PIH or systolic BP, 150 millimeter of mercury. Diastolic BP, 100 millimeter of mercury. Mild PIH, more than 140 but less than 160. More than 90 but less than 110. So systolic BP 150, diastolic 100. What is the management for this patient? Mild PIH, continue, follow up till how many weeks? 37. Follow up till 37. Severe PIH, steroids. Drug of choice for PIH is labetalol. So steroids, labetalol, and follow up till how many weeks? This is the MCQ. 34. Deliver at 34 severe PIH. Deliver at 37 mild PIH. Will you give any drug to treat mild PIH? Come on, everyone. Will you give any drug to treat mild PIH? Do you want to give any drug to treat mild PIH? No, because there are no symptoms in mild PIH, because there is no end organ damage in mild PIH. End organ damage is present in severe PIH. So drug treatment, very good. Drug treatment is given for severe PIH only. Fine, beta. Drug of choice for PIH, labetalol. Drug of choice for chronic hypertension in pregnancy, labetalol. If labetalol is not given in option, alpha methyl dopa. Drug of choice for emergency hypertension in pregnancy, IV labetalol. Don't commit mistake, beta. Emergency hypertension, IV labetalol. If IV labetalol is not given in option, IV hydralazine. IV hydralazine. Fifth MCQ, drug of choice to prevent seizures. Drug of choice to prevent seizures. Come on. Magnesium sulfate. Drug of choice to prevent seizures is magnesium sulfate. Next MCQ, drug of choice to treat seizures. Drug of choice to treat seizures, magnesium sulfate. So drug of choice to prevent seizures, magnesium sulfate. Drug of choice to treat seizures, magnesium sulfate. Drug of choice for PIH is labetalol. Drug of choice for chronic hypertension in pregnancy is labetalol. If not given, then alpha methyl dopa. Mild PIH management. Two questions from this stuff on 12th December. Mild PIH management, no drug required because there are no symptoms, because end organ damage is not seen in mild PIH. Just follow or up till 37. Deliver at induction of labor at 37. Severe PIH, steroids given, labetalol given, and follow up till 34. Management of HELLP syndrome. If HELLP syndrome develops, management of HELLP syndrome is HELLP syndrome. Immediate induction of labor irrespective of gestational age. HELLP syndrome, immediate induction of labor irrespective of gestational age. Tell me the diagnostic criteria for HELLP syndrome. Diagnostic criteria for HELLP syndrome, TENIS criteria. Which criteria? TENIS criteria. Very nice. Management of eclampsia. Management of eclampsia. Immediate induction of labor irrespective of gestational age. Very good. Very nice. Immediate induction of labor irrespective of gestational age. That's for eclampsia. Management of abruptio placentae. Come on, everyone. Management of abruptio placentae. Immediate induction of labor irrespective of gestational age. Question number 1. Question number 2. If DIC has developed in abruptio placentae, management is treat DIC first with fresh frozen plasma and after correction of DIC, induction of labor. In abruptio placentae, bleeding is painful or painless? Painful. Examiner gives you a question. A patient presents to you, maybe after car accident trauma, maybe she is severely hypertensive or any other risk factor for abruptio placentae. She is coming to you with complaint of pain in abdomen. Abruptio placentae pain occurs. Examiner may give two things, either pain abdomen or bleeding per vagina. Bleeding per vagina means revealed abruption. Only pain is concealed abruption. Fetal parts not palpable. Fetal heart sound not audible. What is most likely? Abruptio placentae, 12th December question, already printed in computer, already typed in computer. 12th December question, what is most likely? Abruptio placentae. Or, examiner may not ask like this. This question in computer may be, what should be the best management of this condition? Best management of this condition is immediate induction of labor. In this question only, if examiner writes, fibrin degradation products are increased or D dimer is high, means DIC has developed, then will you go for immediate induction of labor? No, we will correct DIC first and then we will induce labor. 12th December question. If postpartum hemorrhage is not controlled with oxytocin 30 to 40 international units, what is the next step? Give me the answer of the question. Very, very, very important. Out from next 2 minutes, one question on 12th December. From next 2 minutes, one question on 12th December. If postpartum hemorrhage is not controlled by oxytocin 30 to 40 international units IV infusion, what is the very good, very good. Carboprost, बेटा carboprost, ये तीनों नाम याद रख लेना carboprost के. Carboprost is also called Hembate or 15-methyl PGF2 alpha. Carboprost is also called Hembate or 15-methyl PGF2 alpha. Fine. Prophylactic drug of choice for PPH, oxytocin. 10 international units intramuscular injection. Therapeutic drug of choice for PPH, oxytocin. 30 to 40 international units slow IV infusion. Third question, beta. Most potent drug to treat PPH, carboprost. Fourth question, beta. Best drug to treat PPH, carboprost. Don't commit any mistake. Prophylactic drug of choice, oxytocin. Therapeutic drug of choice, oxytocin. Best drug to treat PPH, carboprost. Most potent drug to treat PPH, carboprost. If PPH is not controlled by oxytocin, what is the next step? Carboprost. I am asking you sixth question. If PPH is not controlled by carboprost, what is the next step? Next step is, you know, these drugs, oxytocin drug is given with uterine massage. So uterine massage is recommended by WHO for management of postpartum hemorrhage. Oxytocin with uterine massage is given. Examiner frames the MCQ. Which of the following have been recommended by WHO in the management protocol of postpartum hemorrhage except? In exact, examiner always trap you with uterine packing. Examiner always trap you with uterine packing, but the correct answer is uterine massage. Oxytocin plus uterine massage. Now next question, oxytocin uterine massage not controlled, carboprost. Now next question, if not controlled even by carboprost, what is the next step? Next step is uterine tamponade. Uterine tamponade with either Sanjestaken Blackmore esophageal catheter or condom catheter or Bakri balloon catheter. Fine? You remember uterine tamponade कैसे करते हैं सब पता है खत्म. This is a quick round. If next question, if PPH is not controlled even by uterine tamponade, what is the next step? Next step is bimanual compression of uterus, external aorta compression or military anti-shock garment. Here, if not controlled even after this, if she is a multi-hysterectomy, which hysterectomy is done in PPH? Subtotal hysterectomy. I know, and I will see all these messages after the class also. Who answered and who didn't answer? I will see all these messages after the class, and all these chocolates are due. ये मेरे पास हैं. Whenever we meet, these chocolates, I will keep these chocolates for you. Fine. So, if she is a multiparous, then hysterectomy. Which hysterectomy is done in PPH? Subtotal or supracervical. If she is a primey, then we go for B-Lynch suture or brace suture. Next question. If PPH is not controlled even with brace sutures or B-Lynch sutures, what is the next step? Next step is uterine artery ligation. Please remember the correct sequence of these artery ligation. In INI-CET last session, this was asked, what is the correct sequence of devascularization of these vessels? And we know, first of all, we ligate uterine artery. If no response after ligation of uterine artery, what is the next step? Ligation of ovarian artery. If not responding even after ligation of ovarian artery, what is the next step? Ligation of anterior division of internal iliac artery, because uterine artery is a branch of anterior division of internal iliac artery. Next MCQ. If there is no response or if PPH is not controlled even after devascularization of these vessels, what is the next step? Next step is hysterectomy. Hysterectomy in PPH is subtotal hysterectomy, which is also called supracervical hysterectomy. Supracervical, beta. We remove only uterus, not the cervix. She is a young lady. Fine. If PPH is not controlled even after hysterectomy, what is the next step? Very nice, Asha Singh. Very nice, Asha Singh. Next step is umbrella pack, parachute pack. umbrella pack, parachute pack. So please remember, drug of choice to treat PPH, oxytocin. Drug of choice, prophylactic drug of choice is also oxytocin. Difference in dose. Most common, most potent drug or best drug to treat PPH is carboprol. Please don't commit any mistake in all these things. By the way, tell me what is the most common risk factor for preterm labor? Most common risk factor for preterm labor. History of previous preterm labor. Most common risk factor for ectopic pregnancy. History of previous ectopic pregnancy. Most common risk factor for placenta previa. History of previous placenta previa. Most common risk factor for abruptio placentae. History of previous abruptio placentae. Most common maternal complication of twin pregnancy. Most common maternal complication of twin pregnancy, PPH. Most common maternal complication of shoulder dystocia drill, PPH. Most common neonatal complication of twin pregnancy, prematurity. Most common neonatal complication of shoulder dystocia drill, brachial plexus injury. Brachial plexus injury. High risk choriocarcinoma if score is 7 or more than 7. Gold standard for diagnosis of bacterial vaginosis. Gold standard for diagnosis of bacterial vaginosis, Nugent score. When it is abnormal, if it is 7 or more than 7. If it is 7 or more than 7. What is insular score? Where did we write insular score? Insular score is for very good. Insular score is for cervical mucus. What is a good insular score? Around 10. Good insular score is around 10. If there is poor cervical mucus, and anti-sperm antibodies in the cervix, what is the management? And she wants to conceive. Intrauterine insemination, IUI. Other indications of IUI: mild oligospermia, impotence, vaginismus, epispedia, hypospedia, retrograde ejaculation. According to sperm count, if it is mild oligospermia, that is 10 to 15 million per ml, IUI. Moderate oligospermia, 5 to 10 million per ml, in vitro fertilization. Severe oligospermia, less than 5 million per ml. What we do? Intracytoplasmic sperm injection. How much should be the minimum number of morphologically normal sperms in seminogram? Minimum number of morphologically normal sperms in seminogram, 4%. Minimum progressively motile sperms should be at least 32%. Minimum sperm count should be at least 15 million per ml. At least I will see all the messages, particularly today, who really answered very well. But it will take me 5 hours to see, but I will not sleep. Fine. So minimum sperm count is 15 million per ml. If it is less than 15, oligospermia. 10 to 15, mild oligospermia. 5 to 10, moderate oligospermia. Less than 5, severe oligospermia. If progressively motile sperms are less than 32%, asthenospermia. Morphologically normal sperms less than 4%, teratospermia. How much should be the minimum viable sperm? 58%. If it is less than 58%, it is called necrozoospermia. Very nice. If it is less than 58%, it is called necrozoospermia. Best differentiation in the causes of male factor is by what? We wrote 3: FSH, LH and testosterone. Out of these 3 we discussed in our CCD session also. The best one is FSH. That CCD session you watched, just in 3 hours we discussed 26 clinical questions and how to tackle all those googly balls of 26 clinical questions, along with the various things, tumor markers and everything, that PDF also we covered just in 3 hours. If there is any sort of kilometer long clinical question in our examination, that CCD is enough for everything. You know that. Fine. Now, so after this, let's do some chanting from all-in-one, and then we'll come back to our rapid fire round in between. Come on. Right. So, Normal cycle length is 24 to 38 days. 24 to 38 days. Normal cycle length is 24 to 38. If it is not given in option, second best choice would be 21 to 35. But best answer is 24 to 38. Normal duration of bleeding is 2 to 7 days. Normal duration of bleeding is 2 to 7 days. Normal amount of blood loss is 5 to 80 ml. Everything we have written in our notes. All this is from notes only. LH surge precedes ovulation by 32 to 36 hours. LH peak precedes ovulation by 10 to 12. We discussed now also. By the way, minimum LH required for ovulation is 75 nanogram per ml. Inhibin is secreted by Graafian follicle in female and Sertoli cells in male. Ovulation occurs, a very important question, very important question. Ovulation occurs 14 days after first day of menses or before next menstruation. Before next menstruation. So see this line very carefully. Ovulation occurs 14 days before next menstruation because which half of cycle is fixed? First half or second half? Second half of cycle is fixed. So ovulation does not occur 14 days after first day of menses. Ovulation occurs 14 days before next menstruation. This is why we subtract 14 from cycle length to get the day of ovulation. Now, disorders of menstruation. In disorders of menstruation, what is amenorrhea? Absence of menstruation. Oligomenorrhea, if cycles are after how many days? 38 days. Oligomenorrhea after 38 days. Oligomenorrhea after 38 days. Most common cause of oligomenorrhea, PCOS. PCOS. What's another name of PCOS? Another name of PCOS is Steen-Leventhal syndrome. Steen-Leventhal syndrome. So, oligomenorrhea menses after 38. If 38 is not given in option, after 35. Polymenorrhea, interval of 24. If 24 not given in option, 21. If 24 not given in option, then very good, very nice. If it's 24 not given in option, 21. Most common cause of polymenorrhea is PID. Most common cause of oligomenorrhea, PCOS. Most common cause of oligomenorrhea, PCOS. Most common cause of polymenorrhea or epimenorrhea, PID. Most common cause of polymenorrhea or epimenorrhea, PID. Oligo PCOS, oligo PCOS, poly PID, poly PID. Menorrhagia, uterine fibroid. Most common cause of menorrhagia, uterine fibroid. What is menorrhagia? Amount of menses more than 80 ml or flow more than 7 days. Amount is more than 80 ml or flow more than 7 days. This is menorrhagia. What is metrorrhagia? Metrorrhagia is irregularly timed episodes of bleeding. Irregularly timed. Irregular menses, metrorrhagia. Irregular menses, metrorrhagia. What is the most common cause of metrorrhagia? Most common cause of metrorrhagia. Speak out in your room. Chocolate question of 12th December. Most common cause of metrorrhagia, DUB. If DUB is not given in option, ulcerated endometrial polyp. If DUB is not given in option, ulcerated endometrial polyp. Fine. Hypomenorrhea, less than 5 or less than 2 days. Less than 5 ml or less than 2 days. Most common cause of hypomenorrhea, Asherman syndrome. Important chocolate question. Most common cause of hypomenorrhea, Asherman. Hypomenorrhea, Asherman. PCOS, oligo. Most common cause of oligo, PCOS. Oligo, PCOS. Hypomenorrhea, Asherman syndrome. Polymenorrhea, PID. Polymenorrhea, PID. Menorrhagia, uterine fibroid. Menorrhagia, uterine fibroid. Metrorrhagia, DUB. If DUB is not given in option, ulcerated endometrial polyp. Ulcerated endometrial polyp. Fine. Most common cause of Asherman syndrome is postpartum curettage. Postpartum curettage. How to treat Asherman syndrome? Hysteroscopic adhesiolysis, followed by insertion of balloon catheter, followed by administration of estrogen progesterone. Asherman syndrome, hysteroscopic adhesiolysis, followed by insertion of balloon catheter, followed by administration of estrogen and progesterone. Testicular feminization syndrome, what is given after orchidectomy? TFS, what is given after orchidectomy in testicular feminization syndrome? Only estrogen, only estrogen. In Swyer syndrome, what is given after orchidectomy? Swyer syndrome, what is given after orchidectomy? estrogen plus progesterone, estrogen plus progesterone. Testicular feminization syndrome, orchidectomy is done at what time? After puberty. Sware syndrome, orchidectomy is done at what time? As soon as condition is diagnosed. Most common tumor which may develop if untreated. Most common tumor, risk of most common tumor with testicular feminization syndrome and Sware syndrome is gonadoblastoma. Gonadoblastoma. Risk of most common malignancy. Risk of most common malignancy in testicular feminization syndrome and Sware syndrome, seminoma. TFS Sware syndrome, risk of malignancy, seminoma. Risk of tumor, gonadoblastoma. TFS, orchidectomy is done after puberty. Sware orchidectomy is done as soon as condition is diagnosed. What is the treatment of Turner syndrome? Estrogen plus progesterone. Estrogen plus progesterone. And growth hormone is also given. Treatment of pure gonadal dysgenesis. Treatment of pure gonadal dysgenesis. Estrogen and progesterone. No need for growth hormone. Why and how? Time gaya, hame sab aata hai. We know everything. We know everything. So treatment of Turner, estrogen plus progesterone. Pure gonadal dysgenesis, estrogen plus progesterone. Asherman syndrome, estrogen plus progesterone. Testicular feminization syndrome, only estrogen. Sware syndrome, estrogen plus progesterone. Why and how? We know everything. So don't commit any mistake in choosing what you are doing. Drug of choice for hot flushes. Drug of choice for hot flushes, Tibolol. Drug of choice for osteoporosis. Drug of choice for any type of osteoporosis. Not only postmenopausal osteoporosis. Drug of choice for any type of osteoporosis is bisphosphonate. Menopausal age. Menopausal age. If the question is single liner, how much is the menopausal age? 51. 51. If written menopausal age in India, 47. 47. Most common cause of postmenopausal bleeding. Most common cause of postmenopausal bleeding, endometrial atrophy. Most common cause of postmenopausal bleeding in India, cervical cancer. Most common cancer responsible for postmenopausal bleeding, endometrial cancer. Endometrial cancer. Most common cancer responsible for postmenopausal bleeding in India, cervical cancer. Cervical cancer. Most common symptom of endometrial cancer. Most common symptom of endometrial cancer, irregular bleeding PV. Most common symptom of cervical cancer, irregular bleeding PV. Most common symptom of vesicular mole, irregular bleeding PV. Most common symptom of choriocarcinoma, irregular bleeding PV despite of complete evacuation. All irregular bleeding PV. Irregular bleeding PV. Most specific symptom of cervical cancer or earliest symptom of cervical cancer, post-coital bleeding. Post-coital bleeding. Most specific symptom of endometrial cancer, post-menopausal bleeding. Most specific of endometrial cancer, post-menopausal bleeding. Most specific of cervical cancer, most specific of cervical is post-coital bleeding. This is why I was emphasizing on our TND session and CCD session. If you just watch our TND session, CCD session and this session, फोड़ डालेंगे, फोड़ दिया समझो, हो गया काम. Minimum 50 questions on 12th of December from OBE. I'm telling you. Come on, let's come back to our all-in-one. Okay. Cryptomenorrhea, most common cause. Cryptomenorrhea, most common cause, imperforate hymen. Most common cause, imperforate hymen. Dysmenorrhea, pain at the time of menstruation. Pain at the time of menstruation. Cryptomenorrhea, I will tell you these three questions here only. These three questions here only. A 20-year-old girl presents with primary amenorrhea. Ultrasound was done. And on ultrasound, uterus is present, secondary sexual characters are normal. What is most likely? Cryptomenorrhea. Cryptomenorrhea. Next question. A 23-year-old girl presents with primary amenorrhea, secondary sexual characters are normal, and on per speculum examination, there is tense bluish bulge. What is most likely? Cryptomenorrhea. Third question. A 20-year-old girl presents with primary amenorrhea. Secondary sexual characteristics are normal. Ultrasound reveal absence of uterus and a blind vagina. What is most likely? Mullerian agenesis or Rokitansky-Custer-Meyer-Hauser syndrome. Next question. A 19-year-old girl presents with primary amenorrhea. Her secondary sexual characteristics are normal. Ultrasound revealed absence of uterus. Her axillary and pubic hairs are scanty or absent. What is most likely? If axillary and pubic hairs are scanty or absent, it is testicular feminization syndrome. So be very clear about it. Be very clear. A 22-year-old girl presents with primary amenorrhea and bilateral inguinal hernia. What is most likely? Testicular feminization syndrome. A 24-year-old girl presents with primary amenorrhea, absent secondary sexual characters, and reduced height. What is most likely? Turner syndrome. A 21-year-old girl presents with primary amenorrhea, absent secondary sexual characters, and normal height. What is most likely? Pure gonadal dysgenesis. A 22-year-old girl presents with primary amenorrhea and galactorrhea. What is most likely? Craniopharyngioma. A 24-year-old girl presents with primary amenorrhea and bitemporal hemianopia. What is most likely? Craniopharyngioma. So most common cause of primary amenorrhea, gonadal dysgenesis or Turner. Most common cause of secondary amenorrhea, pregnancy. Most common pathological cause of secondary amenorrhea, PCOS. Most common pathological cause of secondary amenorrhea in developing countries, endometrial TB. Endometrial TB. Come on. So now I am posting at least 25 to 30 questions on Miss Next Telegram daily around 9 p.m. and they are from various subjects, and the questions I devote 2 hours daily to choose those high yield questions from various subjects, and I am posting those, and some of them may be direct on 12th of December from various subjects, not only from Obskyny. So please solve those Telegram questions at Miss Next Telegram, because I am really putting efforts for that, and that will be useful for you, I'm sure. Come on. Dysmenorrhea is pain at time of menstruation. So dysmenorrhea is pain at time of menstruation. What is mid-cycle pain? Come on. Mid-cycle pain is mid-cycle pain. Everyone speak out in the room. Mid-cycle pain is Mittelschmerz. Mittelschmerz. Pain at the time of menstruation is dysmenorrhea. Pain at the time of menstruation is dysmenorrhea. Mid-cycle pain, Mittelschmerz. Mid-cycle spotting, Mittelblue. Management of mid-cycle spotting, Mittelschmerz and Mittelblue. Management of Mittelschmerz and Mittelblue, reassurance. Management of Mittelschmerz and Mittelblue, reassurance. Primary dysmenorrhea, there is no organic pelvic pathology. No organic pelvic pathology. Secondary dysmenorrhea, most common cause, endometriosis, chocolate question. Secondary dysmenorrhea, most common cause, endometriosis. Most common cause of oligomenorrhea. Speak out without all-in-one. Speak out without all-in-one. Now just look in front of, just look at me and speak out. Nobody will see in all-in-one. Just look at me. Most common cause of oligomenorrhea, PCOS. Most common cause of polymenorrhea, PID. Most common cause of hypomenorrhea, Asherman syndrome. Most common cause of Asherman syndrome, postpartum curettage. Most common cause of menorrhagia, uterine fibroid. Most common cause of metrorrhagia, DUB. If DUB is not given in option, ulcerated endometrial polyp. Ulcerated endometrial polyp. Fine, beta. Come on. Dysfunctional uterine bleeding, DUB. When there is no organic pelvic pathology is seen for irregular menstruation. If organic pelvic pathology is seen, that is called AUB, abnormal uterine bleeding. So don't commit any mistake. Dysfunctional uterine bleeding, no organic pelvic pathology. If irregular bleeding PV is associated with organic pelvic pathology, this is called abnormal uterine bleeding or AUB. Now, what are the causes of AUB? Come on, speak out in your room. Everyone, what are the causes of AUB? Abnormal uterine bleeding, palm coin classification, polyp, adenomyosis, leiomyoma, malignancy, coagulation disorder, ovulatory dysfunction, endometrial cancer. Come on, iatrogenic and not yet classified. This is palm coin classification. So if there is irregular bleeding PV with organic pelvic pathology, this is abnormal uterine bleeding. Cause of abnormal uterine bleeding, which classification? Palm coin classification. Which classification? Palm coin classification. Irregular bleeding PV without organic pelvic pathology, dysfunctional uterine bleeding. Diagnostic criteria for PCOS, Rotterdam criteria. Diagnostic criteria for bacterial vaginosis. Come on, diagnostic criteria for bacterial vaginosis, M cell criteria. Gold standard for bacterial vaginosis, new gent score. Treatment regime for eclampsia, pre-chart regime. Treatment regime for high-risk choriocarcinoma, Beck-Shaw regime. Classification for abruptio placentae. Speak out in your room. Classification for abruptio placentae. Page classification. Page classification. Classification of twin-twin transfusion syndrome. Classification of twin-twin transfusion syndrome. Quintro staging. Quintro staging. Twin-twin transfusion syndrome. Quintro staging. Quintro staging. Abruptio placentae, which classification? Page classification. Page classification. Placenta previa classification was given by Dr. Brown. Dr. Brown. Expectant management regime of placenta previa was given by McAfee and Johnson. McAfee and Johnson. Classification of pelvis was given by Caldwell Malloy. Caldwell Malloy. Pap smear was invented by George Papanicolaou. Pap smear was invented by George Papanicolaou. So we should remember these little things. Sometimes examiner may ask various names. So abruptio placentae, which classification? Page classification. Twin-twin transfusion syndrome staging, Quintro staging. Quintro staging. Diagnostic criteria for HELP syndrome. Diagnostic criteria for HELP syndrome. Tennis criteria. Which criteria? Tennis criteria. End organ damage is present in mild PIH or severe PIH. End organ damage is present in mild PIH or severe PIH. It is present in severe PIH only. It is present in severe PIH. Management of preterm labor. What is the management of preterm labor? We have to see what? Gestational age. To solve any MCQ related to management of preterm labor, what we have to see? Gestational age. If gestational age is less than 34 weeks, steroids, tocolytics, and if less than 28, magnesium sulfate. Steroid in India, dexamethasone. Best is betamethasone. Dose of dexamethasone and betamethasone very important. Dexamethasone total dose 24 mg. Betamethasone total dose 24 mg. Dexa subdivided in 4 doses. Beta subdivided in 2 doses. Dexa subdivided in 4, 6 mg, 6 mg, 6 mg, 6 mg. 12 hours apart intramuscular injection. Betamethasone 12 mg, then 12 mg, 24 hours apart intramuscular injection. Fine. And if gestational age is 34 weeks or more than 34 weeks, wait and watch. Wait and watch. Management of premature rupture of membrane. What is the difference in management of prom and preterm labor? Premature rupture of membrane if less than 34 weeks. Steroids, tocolytics if less than 28, magnesium sulfate, and antibiotic. If gestational age 34 or more than 34 weeks, antibiotic and induction of labor. Antibiotic and induction of labor. This is how we manage preterm labor. Drug of choice as a tocolytic, nifedipine. Drug of choice as a tocolytic, nifedipine. Tocolytic of choice in heart disease patient, atosiban. Atosiban. Tocolytic of choice in heart disease patient, atosiban. Drug of choice to prevent neurological complications, magnesium sulfate. Magnesium sulfate. Prophylactic drug of choice for preterm labor. Prophylactic drug of choice for preterm labor is progesterone. I repeat, drug of choice as a tocolytic or tocolytic of choice, nifedipine. Tocolytic of choice in heart disease patient, atosiban. Drug of choice to prevent neurological complications, magnesium sulfate. Prophylactic drug of choice for preterm labor. Prophylactic drug of choice for preterm labor is progesterone. So don't commit any mistake in marking these things. Antenatal complication of postpartum pregnancy. Everyone speak out. Antenatal complication of postpartum pregnancy. Meconium aspiration syndrome. Postnatal complication of postpartum pregnancy. Pneumonia. Most common complication of oligohydramnios. Pulmonary hypoplasia. Most common complication of late oligohydramnios, meconium aspiration syndrome. Most common complication of early oligohydramnios, pulmonary hypoplasia. Overall, most common complication of oligohydramnios, pulmonary hypoplasia. So don't commit any mistake in marking all this. Most common neonatal complication of gestational diabetes. Speak out in your room. Speak out in your room. Most common neonatal complication of gestational diabetes, hypoglycemia. If hypoglycemia is not given in option, hyaline membrane disease, which may result in polycythemia, hyperbilirubinemia, hyperviscosity syndrome, and decreased serum potassium. Fine. What is the clinical suspicion of shoulder dystocia? Clinical suspicion of shoulder dystocia is by what? Clinical suspicion of shoulder dystocia is by which sign? Tell me the sign. Tell me the sign. Clinical suspicion of shoulder dystocia is by which sign? Turtle sign. Clinical suspicion of shoulder dystocia, turtle sign. Most common maternal complication of shoulder dystocia, PPH. Most common neonatal complication of shoulder dystocia, drill, brachial plexus injury. Most common maternal complication of twin pregnancy, postpartum hemorrhage. Most common neonatal complication of twin pregnancy is prematurity. They are just examination questions. Just examination questions. So don't ever commit any mistake. First maneuver or best maneuver for shoulder dystocia drill. First maneuver, best maneuver for shoulder dystocia drill, Mac-Roberts maneuver. Sudden flexion and abduction of maternal lower limb. What is the complication of Mac-Roberts maneuver? Injury to which nerve? Injury to lateral cutaneous nerve of thigh. Second question, if Mac-Roberts maneuver fail, what is the next step? Next step is Wood's cork screw maneuver. If it fails, Javanelli maneuver. Which pressure is given in shoulder dystocia drill? Suprapubic pressure. Suprapubic pressure. Which pressure is given in Burn-Marshall method? Suprapubic pressure. Which pressure is given in Burn-Marshall method? Suprapubic pressure. Suprapubic. So please be very quick. Which pressure is given in Burn-Marshall method? Suprapubic pressure. Which pressure is given in shoulder dystocia drill? Suprapubic pressure. Which pressure is given in normal labor? Fundal pressure. Which pressure is given? Fundal pressure. If after coming head of breech is entrapped, if after coming head of breech is entrapped, what is the next step? What you will look for? We will look for whether this is term or preterm. If it is preterm, Duhr-Sens incision. Duhr-Sens incision. They are applied at what level? 10 and 2 o'clock position. After coming head entrapped and fetus is term. After coming head entrapped and fetus is term. What you are going to do? Javanelli maneuver. Javanelli maneuver. Most common cause of death in breech, intracranial hemorrhage. Most common cause of death in breech, intracranial hemorrhage. Most common cause of breech, prematurity. Most common cause of breech, prematurity. Most common cause of recurrent breech. Most common cause of recurrent breech, congenital malformations of uterus. Congenital malformations of uterus. Let's come back to all in one. Fine. Now, fine. So dysfunctional uterine bleeding, irregular bleeding when no organic pelvic pathology. AUB dysfunction when there is pathology, organic pelvic pathology. Fine. The most common cause of DUB is anovulatory. Most common cause of DUB is anovulatory. Treatment is hormonal. Cause of primary amenorrhea, we discussed this. Cause of primary amenorrhea, most common cause of primary amenorrhea, Turner syndrome. If gonadal dysgenesis is given, gonadal dysgenesis is a broad group. Turner syndrome is a type of gonadal dysgenesis. So if gonadal dysgenesis is given, that will be the best answer. If it is not given, Turner syndrome. Most common cause of secondary amenorrhea. Most common cause of secondary amenorrhea is pregnancy. Primary amenorrhea, Turner. Secondary amenorrhea, pregnancy. Most common cause of postmenopausal bleeding, endometrial atrophy. Most common cause of postmenopausal bleeding, endometrial atrophy. Most common cause of postmenopausal bleeding in India, cervical cancer. Cervical cancer. Earliest menopausal symptom. Earliest menopausal symptom is hot flushes. Drug of choice, Tibolon. Earliest menopausal symptom, hot flushes. Most common menopausal symptom, hot flushes. Most characteristic menopausal symptom, hot flushes. Symptom for which maximum need of treatment with HRT is hot flushes. And drug of choice for hot flushes is Tibolon. Drug of choice for hot flushes is Tibolon. Rule of hormone replacement therapy. What is the rule of hormone replacement therapy? If uterus is intact. If uterus is intact, both estrogen and progesterone are given. But if hysterectomy has been done, only estrogen can be given. We know this thumb rule. So, hysterectomy done, estrogen. Hysterectomy done, estrogen. Uterus intact, estrogen and progesterone. Absolute contraindication for HRT. Absolute contraindication for HRT is history of thrombosis. Absolute contraindication for HRT is history of thrombosis. And if there is thrombosis, transdermal estrogen patches are given. We have clearly written in our note. Drug of choice for osteoporosis is bisphosphonate. Bisphosphonate. Premature menopause if menopause occurs before 40 years. Average menopausal age in India is 47. If India is not mentioned, answer will be 51. Answer will be 51. After menopause, what's happening? After menopause, FSH, LH increase, estrogen, progesterone decrease. After menopause, what is increased? FSH and LH. What is decreased? Estrogen and progesterone. In menopausal state, FSH levels are usually more than 40 because ovary has failed. Positive feedback to FSH. So menopausal state FSH are very high, usually more than 40. After menopause, FSH-LH increased. FSH-LH increased. Estrogen progesterone decreased. Estrogen progesterone decreased. Very important question, very important question for 12th of December. Best indicator of ovarian reserve, anti-Mullerian hormone. Best indicator of ovarian reserve, anti-Mullerian hormone. This is the best. Anti-Mullerian hormone is best because it can be done any day. Second best is FSH, but the problem with FSH is it has to be performed only on day 3 of cycle. Important question for 12 December. Come on, vaginitis. Trichomonas vaginitis is most common vaginitis, but this is highly debatable. Sometimes bacterial vaginosis supersedes, sometimes trichomonas. So don't go in that debate. Yes, this is a better statement. Most common non-viral STD involved. That's true for it. Because bacterial vaginosis is not STD. Bacterial vaginosis is not STD. So most common non-viral STD involved Trichomonas vaginitis. Nature of discharge. Nature of discharge here is profuse greenish colored. Greenish yellow or greenish white. Greenish yellow or greenish white. Plus itching plus urinary symptom. Strawberry vagina, Trichomonas vaginitis. Angry looking vagina, Trichomonas vaginitis. Colpitis macularis, Trichomonas vaginitis. Candidiasis, thick curdy white cottage cheese like discharge. Gram positive yeast like microorganism, pH remains acidic, profuse thick curdy white discharge. Important questions, candidal vaginitis. Nature of discharge, thick curdy white, candida, thick curdy white candida, thick curdy white candida. Greenish white trichomonas, greenish white trichomonas, greenish yellow trichomonas, greenish yellow trichomonas, thick curdy white trichomonas. Maximum itching is seen in candidal vaginitis. Maximum itching is seen in candidal vaginitis. Maximum itching is seen in candidal vaginitis. Most common vaginitis in pregnancy, candidal. Most common vaginitis in OCP user, candidal. Most common vaginitis in HIV positive female, candidal. Most common vaginitis after prolonged use of steroid, candidal. Most common vaginitis after prolonged use of antibiotic, candidal. Treatment of male partner trichomonas always done. Candidal if male is symptomatic then only. Bacterial vaginosis treatment of male partner not required. Itching is absent. TLC ESR may be normal. Chlamydial vaginitis we are even searching for male partner. Trichomonal vaginitis metronidazole 2 grams single dose. If not given in option 500 milligram TDS for 7 days. Candidal vaginitis fluconazole 150 milligram stat single dose. Chlamydial vaginitis azithromycin plus contact tracing. Bacterial vaginosis metronidazole 500 milligram TDS for 7 days. Pregnancy. Pregnancy, first trimester, no treatment anywhere. Second and third trimester, treatment is same for trichomonal vaginitis and bacterial vaginosis, 250 milligram TDS for 7 days. 250 milligram TDS for 7 days. Candidal vaginitis, clotrimazole and miconazole, local application. Gold standard for bacterial vaginosis, Nugent score. What is pathological score? 7 or more than 7. Most pathognomonic of bacterial vaginosis, presence of clue cells. They should be more than how much? 20%. They should be more than how much? 20%. How you get clue cells? By addition of sodium chloride to the discharge. By addition of sodium chloride to the discharge. Furning in cervical mucus is present in proliferative phase or secretory phase? Proliferative phase. This furning is due to what? Sodium and chloride. This furning is due to what? Sodium and chloride. How do you get Whiff's test in bacterial vaginosis? Add 10% QS to discharge. Fishy odor, Whiff's test positive. Diagnostic of bacterial vaginosis. Where else we use 10% QS? Single alkali denaturation test or APTAS. We add 10% QS to the blood. Fetal blood, resistant to alkali, so not denatured. So how to differentiate fetal and maternal blood in suspicion of Vasa previa? By Singer's alkali, 12th December question, Singer's alkali denaturation test or APTAS. What is the principle of test? Principle of test is fetal blood is resistant to alkali. What is the reagent used in this test? 10% KOH. If it is fetal blood, denatured or not denatured? Not denatured. Two important questions. Diagnosis of Vasa previa is by color Doppler ultrasound. Color Doppler ultrasound. Treatment of Vasa previa is cesarean section. Treatment of Vasa previa is cesarean section. Vasa previa is a complication of filamentous insertion of umbilical cord. Vasa previa is a complication of filamentous insertion of umbilical cord. Treatment of Vasa previa is cesarean section. Come on, let's come back to all in one. Fine. Bacterial vaginosis is alteration in microbial flora. Alteration in microbial flora and associated with reduction in lactobacilli. So bacterial vaginosis, lactobacilli decrease and Gardnerella increase. Diagnosis is by which criteria? Diagnosis is by M-cell criteria. Grayish white smelling discharge, pH is more than 4.5, clue cells more than 20%, itching is absent. Important question, beta. Itching is maximum itching is seen in which vaginitis? Come on, speak out in your room. Maximum itching is seen in which vaginitis? Maximum itching is seen in. All of you are answering with so much devotion and dedication. I'm really feeling so happy. It indicates how much are you prepared. It indicates how well are you prepared. How well are you prepared. And all these students, they are also complaining of some anxiety. So hence prove that you are really prepared well. So happy. All of you are 200 plus. Take it from me. All of you who are answering are 200 plus. That's why you are answering. Otherwise, how could you find the courage to answer? So that's diagnostic itself. Male partner treatment is not required. Male partner treatment is not required in bacterial vaginosis. Treatment is metronidazole. First trimester, nowhere any treatment. Polycystic ovarian syndrome, PCOS. Just have this kind of energy while answering question. Just because if you have this kind of energy, when we feel energetic, our brain, our neurotransmitters, our emotions, our ideas, our thought process, our recall is also in a flow. Everything is in a flow. Everything becomes dynamic. So be dynamic right now. Polycystic ovarian syndrome. These days it is called PCOS, new name. Most common age group 15 to 25. 15 to 25. PCOS, most common cause of an ovulation. Most common cause of an ovulation, PCOS. Let's crack 4 MCQ quickly. 4 MCQs quickly. Most common cause of infertility and ovulation. Most easily diagnosed cause of infertility and ovulation. Most easily treatable cause of infertility and ovulation. Hence, most reversible form of infertility and ovulation. Most reversible form of infertility and ovulation. And PCOS is most common cause of an ovulation. And most common cause of oligomenorrhea, by the way, most common cause of oligomenorrhea is PCOS. PCOS. Come on, quickly. Let's come back to all-in-one. What is increased and what is decreased in PCOS? The best way to remember is our that formula which we discussed in notes. I will also modify this in next edition of Mist All-in-One. So let's remember that way only. That's the best way to remember. Come on. If you get any question in examination, what is increased in PCOS, what is decreased in PCOS? Insulin, increase. Plasma glucose, increase. So sex hormone binding globulin, decrease. So free androgens, increase. So estrone, increase. So FSH, decrease. So LH, increase. Which estrogen is increasing in PCOS? Estrone. Normal E2-E1 ratio, 2:1. In PCOS, it becomes 1:2 because E1 is estrone and E2 is estradiol. Normal FSH-LH ratio 2:1. In PCOS, it becomes 1:2. 1:2. Please don't commit anything wrong in examination. It's very simple. Now, acne, hirsutism, oligomenorrhea, infertility. They are all features of PCOS. So you will get a question, 23-year-old girl presents with acne, hirsutism, oligomenorrhea. What is most likely? Answer is PCOS. Most common cause of female pseudohermaphroditism is congenital adrenal hyperplasia. And most common cause of male pseudohermaphroditism is androgen insensitivity syndrome. Be very clear. Two important questions. Most common cause of female pseudohermaphroditism, congenital adrenal hyperplasia. Most common cause of male pseudohermaphroditism, androgen insensitivity syndrome. Androgen insensitivity syndrome, male pseudo. Congenital adrenal hyperplasia, female pseudohermaphroditism. PCOS, just quickly let's crack two other questions. 23-year-old girl, acne, hirsutism, oligomenorrhea. What is most likely? PCOS. Next question. 23-year-old girl presents with sudden onset of acne, hirsutism, oligomenorrhea. What is most likely? Androgen secreting ovarian tumor. Or if virilizing features are also added, that is more supportive. 23-year-old girl, sudden onset of acne, hirsutism, alopecia, and hoarseness of voice, androgen secreting ovarian tumor. Clitoromegaly, androgen secreting ovarian tumor. Atrophy of breast, androgen secreting ovarian tumor. Masculine body contour, androgen secreting ovarian tumor. So don't commit any mistake in marking. Drug of choice for infertility due to PCOS, letrozole. Drug of choice for hirsutism in PCOS, OCP. Drug of choice for hirsutism in PCOS, if OCP is not given in option, spironolactone. Spironolactone. Maximum hyperstimulation syndrome is associated with HMG. Hyperstimulation, HMG. Hyperstimulation, HMG. Clomiphene also causes hyperstimulation. Pulsatile GnRH also causes hyperstimulation. But maximum risk of hyperstimulation syndrome is associated with HMG, human menopausal gonadotrophin. So PCOS, don't commit any mistake in answering. And second thing, Rotterdam criteria, 3 points. One is menstrual dysfunction. Second is clinical or biochemical evidence of increased androgens. Third is ultrasound. Ultrasound, examiner will trap you. Ultrasound features in both ovary should be present, or in one ovary are diagnostic. Even if they are present in one ovary, examiner will write one ovary is normal, other is showing this and this. PCOS may be there. In PCOS, what are ultrasound criteria? Follicle size between 2 to 9 mm. Number of follicles should be at least 12. Ovarian volume should be at least 10 cc. What is not included in Rotterdam criteria is necklace sign or string of pearl sign. Necklace sign or string of pearl sign is a feature of polycystic ovarian syndrome, but it is not at all included in Rotterdam criteria. So be very clear in marking these. Most common congenital malformation of uterus. Speak out in your room. Most common congenital malformation of uterus, septate. Septate. Second most common, bicornuate, unicollis. Unicollis. If Mullerian ducts don't fuse at all, diidal phase. If they fuse partially, bicornuate. If they fuse but inner walls don't disappear, septate. If they fuse but inner walls disappear partially, subseptate. If only one Mullerian duct develops, unicornuate. Flat-topped uterus, arcuate. Single fallopian tube in which malformation? With malformation. Speak out in your room. Single fallopian tube in which malformation? Unicornuate. Two vagina in which malformation? Uterine didelphys or double uterus. Uterine didelphys or double uterus. So in a HSG image, two Leach-Wilkinson cannula will be seen in which malformation? Uterine didelphys or double uterus. What is the indication of management of congenital malformation of uterus? Indication of management of congenital malformation of uterus is history of recurrent abortion. History of recurrent abortion. Worst reproductive outcome. Worst reproductive outcome, septate. Second worst, if septate not given in option, unicornuate. Best reproductive outcome, best, arcuate. If arcuate not given in option, bicornuate. What is the name of repair for bicornuate uterus or name of repair for uterine didelphys? Metroplasty. Metroplasty. Which metroplasty is best? Hysteroscopic. If hysteroscopic is not given in option, abdominal, which was started by Strassman. Originally, it was started by Strassman. So, hysteroscopic resection of septum is done for septate uterus. If there is transverse vaginal septum which is causing cryptomenoria, if there is transverse vaginal septum which is causing cryptomenoria, what is the management? Septal resection. No hysteroscope required. Hysteroscopic resection of septum is done in septate uterus. Transverse vaginal septum, septal resection. Asherman syndrome, which adhesiolysis? Hysteroscopic adhesiolysis. Endometriosis, which adhesiolysis? Laparoscopic adhesiolysis. Best drug to treat endometriosis. Best drug to treat endometriosis, continuous GnRH. Most commonly used drug to treat endometriosis, progesterone. Progesterone. So be very, very clear. Be very clear. PV finding in endometriosis. PV finding in endometriosis. Fixed retroverted uterus. Fixed retroverted uterus. Cobblestone field and adnexal mark. Ultrasound finding of ovarian cyst in endometriosis. Ground glass appearance. Laparoscopy finding of ovarian cyst. Chocolate cyst. What is Allen-Masters syndrome? Allen-Masters syndrome, tear of ligament, broad ligament of uterosacral ligament in endometriosis. What is Fitz-Curtis syndrome? Chronic PID, pain in right hypochondrium due to perihepatic adhesion. What is corpus cancer syndrome? Corpus cancer syndrome, endometrial cancer, diabetes, hypertension, obesity. Endometrial cancer, diabetes, hypertension, obesity. Which histopathological variety of endometrial cancer is most common? Most common histopathological variety of endometrial cancer, type 1 cancer, which is also called endometrioid adenocarcinoma. Tell me the gene mutation of type 1 endometrial cancer. Gene mutation of type 1 endometrial cancer, P10 and KRAS. P10 and KRAS. Gene mutation of type 2 endometrial cancer, P53. P53. Type 1, P10 and KRAS. Type 2, P53. Gene mutation of polycystic ovarian syndrome, CYP21. CYP21. Genetics involved in fibroid. Genetics involved in fibroid. Translocation of 12 to 14. Translocation of chromosome 12 and 14. That is the genetics involved in uterine fibroid. Fine. So let's come back to our all-in-one. All this, whatever we are doing today, I think is going to help for 12th December. This is the only idea. This is the only idea for this session. Let me just take 30 seconds to put my MacBook on charging. Fine. That's fine. Okay. Infertility. Best test to diagnose an ovulation. Best test to diagnose ovulation or anovulation is serum progesterone. Best is serum progesterone. Best is serum progesterone. We have clearly written in our note. While most common test to diagnose ovulation is serial ultrasonography. Best test to diagnose ovulation, serum progesterone. Serum progesterone. Most common test to diagnose ovulation is serial ultrasonography. Ultrasound is started day 10 onwards. Which day? Day 10 onwards. What is the evidence of ovulation? Speak out in your room. Ruptured follicle. collapsed follicle plus free fluid in pouch of tug. Evidence of ovulation is collapsed follicle plus free fluid in pouch of tug. Best day for tubal patency. Best test for tubal patency is laparoscopic chromoperturbation. Laparoscopic chromoperturbation, it is done on which day? Another important MCQ. Best day for tubal patency, that is laparoscopic chromoperturbation, is done on which day? Day 10. Day 10. Serial ultrasound to diagnose ovulation is started on which day? Day 10. Serial ultrasound is started on which day? Day 10. Laparoscopic chromoperturbation done on which day? Day 10. Best test to diagnose tubal patency, laparoscopic chromoperturbation. Best test to diagnose ovulation, serum progesterone. Most common test to diagnose ovulation, serial ultrasonography. Serial ultrasonography. If ovulation has occurred, progesterone should be at least. If ovulation has occurred, progesterone should be at least how much? Come on, come on, come on, come on. The only idea behind everything is may all of you pass, may all of you get as many marks as possible. If ovulation has occurred, progesterone should be at least 3 nanogram. Wow, 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 wow. Wow, my God, long list of 3. It should be at least 3 nanogram per ml. 3. And to diagnose ovulation, it is tested on which day post ovulation? It is tested on which day post ovulation? Great! 8-day post ovulation. Means it is which day of cycle? It is which day of cycle? Great! It is 22 day of cycle. Day 22 of cycle. Oh, where else did we write 3333? 3333. Maximum doses of methotrexate to treat ectopic pregnancy. How many maximum doses of methotrexate to treat ectopic pregnancy can be given? 3. 3. And if fall in beta HCG on day 7 is more than 15%, if fall in serum beta HCG on day 7 is more than 15%, what is the next step? Weekly estimation of beta HCG till फिर आ गया 3. Till 3 negative consecutive reports are negative. Till 3 consecutive reports are negative. Vesicular mole, suction evacuation done in primi, hysterectomy done in multi. Even after hysterectomy and suction evacuation, weekly estimation of beta HCG till how many reports are negative? 3. What is the difference in ectopic and mole follow-up? In ectopic, we stop at 3, but in mole, even if 3 weekly reports are negative, we continue follow up till, very nice, we continue follow up till 6 months, every month till 6 months, every month till 6 months. Low risk choriocarcinoma, follow up of beta HCG for 1 year. High risk choriocarcinoma, follow up with beta HCG for 2 years, 2 years, 2 years. Investigation of choice for choriocarcinoma, important question is beta HCG, serum beta HCG. Investigation of choice for complete mole, ultrasound. Gold standard for both complete mole and partial mole. Gold standard for both complete mole and partial mole, histopathology. Gold standard for endometriosis, histopathology. Gold standard for adenomyosis, hysteroscopic curettage. Gold standard for fibroid, MRI. Gold standard for congenital malformations of uterus, combination of laparoscopy and hysteroscopy. Combination of laparoscopy and hysteroscopy. Diagnostic criteria for PCOS, Rotterdam criteria. Diagnostic criteria for bacterial vaginosis, M-cell criteria. But gold standard for bacterial vaginosis, which score? Nugent score. Nugent score. Don't commit any mistake. Management resign, eclampsia, Pritchard. High risk choriocarcinoma, Backshaw, Emeco, fine. And low risk choriocarcinoma, methotrexate, single drug. Drug of choice to treat ectopic pregnancy, methotrexate. Drug of choice to treat ectopic pregnancy, methotrexate. चलो अभी इतना, फिर ऑल इन वन पे आते हैं, फिर वापस जाएंगे. चलो, लेट्स कम बैक टू ऑल इन वन. हाँ जी, चलते हैं जी. चलो, टेस्ट फॉर सर्वाइकल फैक्टर. Test for cervical factor is Sims or Hunner's test. Treatment of choice is intrauterine insemination. What is another name of Sims test or Hunner's test? Another name of Sims test or Hunner's test. Come on, everyone. Another name of Sims test or Hunner's test. Postcoital test. Next question. Postcoital test is done on which day? Postcoital test is done on which day? Postcoital test is done on which day? Day 10 to 12. PCT is done on day 10 to 12. 10 to 12. Fine. Very nice. Drug of choice for an ovulation. Drug of choice for an ovulation with hyperestrogenemia, clomiphene citrate. But in this question, if PCOS is written, drug of choice for an ovulation with hyperestrogenemia, PCOS is a hyperestrogenic condition. But if PCOS is mentioned, answer will be letrozole. If PCOS is mentioned, answer will be letrozole. With hypoestrogenemia, of course, GnRH and FSH. Treatment of choice for tubal cause, best is IVF. Treatment of choice for tubal cause, best is IVF, in vitro fertilization. But please, few tricky questions. Treatment of choice for tubal cause, IVF. Now, examiner tells you a patient presents with bilateral tubal block and husband's seminogram shows sperm count. Husband's seminogram shows sperm count 4 million per ml. 4. Bilateral tubal block with husband's seminogram 4 million per ml. What is the management of your choice? Bilateral tubal block. Husband semi. Very good, Vishal. Very good, Vishal. Very good, Sabni. Very good. Very good, Ronnie. Very nice. Intracytoplasmic sperm injection. So please read the question carefully. Treatment of choice for tubal block is IVF. But if there is severe oligospermia, management would be ICSI. Next question. A patient presents with bilateral cornual block. What is the most likely cause? A patient presents with bilateral cornual block. What is most likely? Bilateral cornual block, answer is physiological spasm. Physiological. Second question. Most common pathological cause of bilateral cornual block. Most common pathological cause of bilateral cornual block, TB. Very nice. Most common pathological cause of bilateral cornual block, TB. Tell me, genital TB, if there is bilateral cornual block and she wants to conceive, bilateral cornual block, she wants to conceive, what is the best management for her? Option A, IVF. Option B, anti-tubercular therapy. Option A, IVF. Option B, IVF. Srishti, very nice. IVF, Rachna, superb. IVF. Why not? Because anti-tubercular therapy will not treat tubal block. Anti-tubercular therapy can only kill Mycobacterium. Very good. Very good. I am getting many Athanshila, very nice. Akash, very good. But many answers from unsaved number. Unsaved number. So usually what I do when students ask me their difficulties, I save their number. When I save their number, so they are able to see my WhatsApp status daily. I post something on my WhatsApp status. But today what I will do, there are so many unsaved numbers. So if you write your name, I will save them. Fine. Come on. Endometriosis. Most common site of endometriosis is ovary. Most common site is ovary. Most common site is ovary. Second most common site of endometriosis. Come on, everyone. Second most common site of endometriosis is pouch of Tugler. If ovary not an option, pouch of Tugler. Most consistent symptoms, secondary dysmenorrhea. Secondary dysmenorrhea. Tell me triad of endometriosis. Tell me triad of endometriosis. Come on. Which of the following is triad of endometriosis? Chocolate question. Dysmenorrhea, dyspareunia and infertility. I won't take much of the time of yours to ask. I will just wait for 1 second and then I will start answering because your time is very precious. Just 8 days before exam, our idea behind this session, what I am thinking, that I am really able to contribute something for 12 December today. This is what my thinking is. So triad is dysmenorrhea, dyspareunia, infertility. Dysmenorrhea, dyspareunia, infertility. Investigation of choice is laparoscopy. Gold standard, don't commit any mistake. Investigation of choice is lapro, but gold standard is histopathology. Gold standard is histopathology. Chocolate seen in it, बच्चा जानता है. गांव का भी, शहर का भी. Best treatment is GnRH analog. Best is GnRH analog. Most common is progesterone. Most common is progesterone. And in laparoscopy, two important questions. Cystectomy is done if size of cyst is 3 centimeter or more than 3 centimeter. If size of cyst is less than 3 centimeter, cyst aspiration is done. If size of cyst is less than 3 centimeter, cyst aspiration. If size of cyst is 3 or more than 3 centimeter, cystectomy. Cystectomy. Fine. Now, pelvic inflammatory disease. Pelvic inflammatory disease, PID. Inflammation of upper genital tract. Fine. बच्चा बच्चा जानता है. Gold standard for PID is laparoscopy. Gold standard for PID is laparoscopy. Most common site, fallopian tube. In fallopian tube, which one is most common? Ampulla. Fallopian tube, which one is most common? Ampulla. Let's crack few chocolates of ampulla. Most common site of fertilization, ampulla. Most common site of genital TB, ampulla. Widest and longest part of fallopian tube, ampulla. Most common site of ectopic pregnancy, ampulla. Ampulla is most common site of ectopic pregnancy because, important question, ampulla of fallopian tube is most common site of ectopic pregnancy because option A, it is widest and longest. Option B, fertilization occurs here. What is the answer? Ampulla is most common site of, we have written in our notes, ampulla is most common site of ectopic pregnancy because option A, it is widest and longest. Option B, fertilization occurs here. Answer is because fertilization occurs here. 12th December question. 12th December question. Ampulla is most common site of ectopic pregnancy because fertilization occurs here. Come back to all-in-one. हम कहाँ भाग गए ampulla से? चलो जी, वापस आते हैं. Most common site involved fallopian tubes. Which part of fallopian tube? Ampulla. Most common symptom in PID, lower abdominal pain. Most common symptom of genital TB, infertility. Treatment of PID, antibiotics plus metronidazole. Treatment of genital TB, 6 months ATT. 6 months ATT. Fine? चलो जी, जल्दी से थोड़ा सा और. A 18-year-old virgin girl. A 18-year-old virgin girl presents with bilateral adnexal masses. Presents with bilateral adnexal masses. What is most likely? Genital TB. Genital TB, most common primary site, lung. Most common route of spread of genital TB. Most common route of spread of genital TB, hematogenous. This is why it is always bilateral. Only pelvic infection which is possible in a virgin girl is TB because it is descending from lungs to here. Otherwise, PID, only possible cause of PID is intercourse. This is why most common risk factor for PID is intercourse with multiple partners. Most common microorganism involved in PID, chlamydia. Most common microorganism responsible for acute PID, gonorrhea. Most common microorganism responsible for PID due to IUCD, actinomyces. Most common microorganism, chlamydia. Acute PID, gonorrhea. Due to IUCD use, actinomyces. Most common risk factor for PID, intercourse with multiple partners. Intercourse with multiple partners. Most common risk factor for ectopic pregnancy, history of previous ectopic pregnancy or previous tubal surgery. Most common risk factor for preterm labor, history of previous preterm labor. Most common risk factor for placenta previa, history of previous placenta previa. Most common risk factor for abruptio placentae, history of previous abruptio placentae. Most common cause of cancer cervix, HPV 16. Most specific for cancer cervix, HPV 18. 16 causes which cancer? Squamous cell carcinoma. 18 causes which cancer? Adenocarcinoma. Most common route of spread in endometrial cancer. Come on, speak out. This is why I'm going from here and there. That's what you will be doing on 12th of December for 19 subjects. Most common route of spread of endometrial cancer, direct spread. Very nice. Most common route of spread in puerperal sepsis. Most common route of spread in puerperal sepsis, direct spread. Most common route of spread of cervical cancer. Come on, speak out. Most common route of spread of cervical cancer, lymphatic. Most common lymph node involved in cancer cervix. Most common lymph node involved in cancer cervix, obturator. Sentinel lymph node in cancer cervix. Come on, everyone. Sentinel lymph node in cancer cervix. Paracervical. If paracervical is not given in option, ureteric. If paracervical is not given in option, ureteric. So most common cause of death in cancer cervix. Most common cause of death in cancer cervix. Renal failure. Most common cause of death in uterine inversion. Most common cause of death in uterine inversion. Come on. Which shock? Neurogenic or hemorrhagic? Hemorrhagic shock. Most common cause of death in uterine inversion, hemorrhagic shock. Pain in uterine inversion is due to what? Neurogenic shock. Pain in uterine inversion is due to neurogenic shock. Most common cause of death in uterine inversion is hemorrhagic shock. Most common cause of shock after delivery, postpartum hemorrhage. Most common cause of shock immediately after delivery, uterine inversion. Most common cause of unexplained shock after delivery, amniotic fluid embolism. We clearly discussed these three things in our CCD session. CCD session, we discussed all these three MCQs in detail with a long clinical question. I am repeating out of these three, expecting one on 12th of December. Most common cause of shock after delivery, postpartum hemorrhage. Question number 2. Most common cause of shock immediately after delivery, uterine inversion. Most common cause of unexplained shock after delivery, amniotic fluid embolism. Beautifully we discussed in our CCD session. Just a 3 hour session with 26 long clinical questions. If any one of you didn't watch, please do watch OBG TND and CCD session and this session, and everything is done. 50 out of 50 from Obs Gynae. Come on, let's come back to all in one. Uterine prolapse. Maximum ligamentous support. Maximum ligamentous support to uterus is by which ligament? Cardinal ligament. Maximum ligamentous support by which ligament? Cardinal ligament. Overall most important support of uterus is levator ani. Overall most important support of uterus is levator ani. Maximum ligamentous support is by cardinal ligament. Most common prolapse is cystocele. Main symptoms are ulcer and pain. If female wants to retain menstrual functions, treatment is for the jail. थोड़ा सा खेलते हैं. Let's play with prolapse for 2 minutes only. 2 minutes play with prolapse. 2 minutes play with prolapse. Come on. Cause of ulcers. Cause of ulcers in uterine prolapse. Important chocolate question for 12th December. Most common cause of ulcers in prolapsed area is venous congestion. Answer is venous congestion. Most common risk factor for uterine prolapse, mismanaged second stage of labor. Most common risk factor for uterine inversion, mismanaged third stage of labor. To solve any MCQ related to prolapse, what we have to see? Parity. Nulliparous or multiparous. Management of prolapse in nulliparous. Abdominal sling operation or cervicopexy. Purandare is best. Management of prolapse in multiparous. Ward Mayo vaginal hysterectomy. Management of prolapse in multiparous, unwilling for hysterectomy around 40 years. Father Gills or Manchester operation. Management of prolapse in 60 or 60 plus lady. Leaf Fort colpoclysis or Daniel stitching. Management of vault prolapse. Sacral colpopexy and sacrospinous fixation. Best is sacral colpopexy. Management of prolapse in pregnancy, in puerperium, in young girl who is unwilling for surgery or in whom there are contraindications for surgery, ring pessary. Most common prolapse overall is cystocele. Most common risk factor for uterine prolapse, mismanaged second stage of labor. Most important risk factor for uterine inversion, mismanaged third stage of labor. Most common cause of vaginal wall prolapse, endopelvic fascia defect. Vaginal wall prolapse, endopelvic fascia defect. Most common vaginal wall prolapse, cystocele. Overall most common prolapse is also cystocele. Management of cystocele and urethrocoele, anterior colporrhaphy. Rectocele and lex perineum, पीछे वाले, posterior, posterior colpoperineorrhaphy. Antrocele, Moskowitz repair. Fine. To solve any MCQ related to management of fibroid, we will see symptoms. If she is asymptomatic and size of fibroid less than 10 centimeter, just follow up with ultrasound, no treatment. If symptoms are present, no need to see any sign. Treatment of fibroid mainly surgical. If she is multiparous, total abdominal hysterectomy. Nulliparous, myomectomy. if unwilling or some contraindication. Multiparous uterine artery embolization with polyvinyl alcohol and ether, or high intensity ultrasound wave therapy under MRI guidance. Nulliparous continuous GnRH. Mifepristone, ulipristal. Oral combined pill, danazol, gastrinone, letrozole. So, what is the difference in treatment of endometriosis and fibroid? In endometriosis, most commonly given drug was progesterone. Best drug, continuous GnRH, continuous. Most common is progesterone. Are we giving progesterone to treat fibroid? No. Because fibroids are both estrogen and progesterone dependent tumor. So treatment of fibroid, continuous GnRH, mifepristone, ulipristal. Treatment of endometriosis, continuous GnRH best, progesterone most common. We can't give progesterone to treat fibroid. What we are giving? Mifepristone, ulipristal, which are anti-progesterone. Rest everything is same. Oral combined pills we are giving to treat endometriosis, but not to treat fibroid because they contain both estrogen and progesterone. Fine. What is done to treat local menorrhagia? Tranexamic acid. Injection tranexamic acid. Where else did we use tranexamic acid? Treatment of postpartum hemorrhage. When she is bleeding profusely, immediately what you give? Injection tranexamic acid IV 1 gram. Come on, let's come back to all in one. We can't make these sessions very lengthy because ultimately you have to get the output of the session. Input-output ratio is very important. How much input of time is required? This is why I am saying just if you are able to revise OBG revision video, TND, CCD and this, OBG is done for this session. Fistula, most common is vesicovaginal fistula. Most common cause of vesicovaginal fistula in developing countries. Developed countries, simple hysterectomy. In developing countries, it is obstructed labor. Developing countries, obstructed labor. Developed countries, simple hysterectomy. Screening test is methylene blue 3 swab test. Screening test is methylene blue 3 swab test, while gold standard is cystoscopy. So screening test for fistula, methylene blue 3 swab test, gold standard is cystoscopy. Treatment of vesicovaginal fistula, Chesser-Moyer or Let's Go treatment. Treatment of uretrovaginal fistula, Boari flap. So vesicovaginal, Chesser-Moyer, let's go. Vesicovaginal, Chesser-Moyer, let's go. Uretrovaginal, Boari flap. Uretrovaginal, Boari flap. Uretrovaginal, Boari flap. Vesicovaginal, Chesser-Moyer, let's go. Chesser-Moyer, let's go. Most common cause of vesicovaginal in developing country. Developing country, obstructed labor. Developing country, obstructed labor. Developed country, simple hysterectomy. Subdeveloped country, simple hysterectomy. Screening test to diagnose fistula, methylene blue 3 swab test. Gold standard to diagnose fistula, cystoscopy. And what you have to remember, if only symptoms are written, we will choose screening test. If name of fistula is written, we will choose diagnostic test. Name of fistula written, diagnostic test. Only symptoms are written, methylene blue 3 swab test. Fine. Vesicovaginal fistula, dribbling, continuous dribbling of urine plus normal micturition or no? No. Dribbling of urine through vagina plus normal micturition, uretrovaginal. Dribbling of urine through vagina only at the time of micturition, urethrovaginal. Management is done if diagnosed within 24 hours, immediately. If after that, after 6 weeks. For uretrovaginal, it is done immediately. Causes of menorrhagia, utrovesical fistula and endometriosis of bladder. Most common cause of utrovesical fistula, cesarean section. Cesarean section, because that is the most common surgery performed on uterus. Most common cause of rectovaginal fistula, speak out. Most common cause of rectovaginal fistula, complete perineal tear. Most common cause of complete perineal tear, occipito-posterior position. Occipito-posterior position. Come on. Cancer cervix. It is most common cause and most common cancer causing postmenopausal bleeding in developing country. Worldwide, which cancer is common? Commonest, carcinoma breast. Most common risk factor for cancer cervix, HPV 16. Most common histological type is squamous cell carcinoma. 16 causes squamous. HPV 18 is most specific, most common subtype leading to adenocarcinoma. Adenocarcinoma is most commonly caused by 18. Squamous is most commonly caused by HPV 16. 16 is most common subtype leading to squamous cell carcinoma. 18 is most specific for carcinoma cervix. So don't commit any mistake. Most common cause is HPV 16. Most specific for cancer cervix is HPV 18. Most common site is squamocolumnar junction, which is also called transformation zone. So most common site for cancer cervix, transformation zone. Most common site for cancer cervix, transformation zone. Most common symptom of cancer cervix. Most common symptom of carcinoma cervix is irregular vaginal bleeding. Irregular. Earliest symptom, post-coital bleeding. Screening test is Pap smear. Most common cause of death is renal failure. Most common cause of death is renal failure. Endometrial cancer, most common histological type, endometrial adenocarcinoma. And which one is most common? Type 1. Type 1 is most common. Type 2 is rare but most dangerous. Most dangerous is type 2. In type 2, which one is most dangerous? Clear cell carcinoma. Which one is most dangerous, beta? Clear cell carcinoma. Most common symptom of endometrial cancer is post irregular bleeding PV. Most common symptom is irregular bleeding PV. Most specific is post-menopausal bleeding. We discussed in detail. Screening test for endometrial cancer is endometrial aspiration biopsy. Gold standard test for endometrial cancer. It depends on if it is diffuse thickening of endometrium, hysteroscopic fractional curettage. Gold standard for diffuse thickening of endometrium, hysteroscopic fractional curettage. Gold standard for focal thickening of endometrium, hysteroscopic biopsy. Gold standard for focal thickness of endometrium, we have clearly written in our notes. Gold standard for focal thickening of endometrium, hysteroscopic biopsy. Gold standard for diffuse thickening of endometrium is hysteroscopic fractional curettage. This all in one obs-gynae portion particularly and other subjects also, they will be drastically changed in next edition. First step in investigation. First step in investigation is endometrial aspiration cytology or endometrial aspiration biopsy. The gold standard for endometrial cancer, if there is diffuse endometrial thickening, hysteroscopic fractional curettage. Hysteroscopic fractional curettage. If there is focal endometrial thickening, hysteroscopic biopsy. Fine. Few questions. We are starting obstetrics here. So just before moving to obstetrics, just few things which I think. So if a patient presents with postmenopausal bleeding, what is the next step? Ultrasound. In ultrasound, if endometrial thickness is more than 4 mm, what is the next step? Endometrial aspiration biopsy. Gold standard to diagnose endometrial cancer if endometrial is diffusely thickened, more than 4 mm, 7, 8, 9, 10, 11, 20, 30, whatever it is. Diffusely thickened, hysteroscopic fractional curettage. Focal thickening of endometrium, hysteroscopic biopsy. Most common histopathological finding type 1 or endometrioid. Rare but more dangerous is type 2. Gene mutation type 1 P10 and KRAS. Gene mutation type 2 is P53. Staging of endometrial cancer quickly. Stage 1A, endometrium and less than 50% of myometrium. 1B, 50% or more than 50% of myometrium. Stage 2, cervix. 3A, serosa adnexa peritoneum. 3B, vagina. 3C1, pelvic lymph node. 3C2, para-aortic lymph node. 4A, regional metastasis, urinary bladder, rectum. 4B, distant metastasis. 3 important questions. Endometrial cancer with ascites, 3A. Endometrial cancer with vagina, 3B. Endometrial cancer with inguinal lymph node, 4B. Endometrial cancer with pelvic lymph node, 3C1. Endometrial cancer with para-aortic lymph node, 3C2. Management. Stage 1A grade 1-2. 1A grade 1-2. TAH plus BSO. TAH plus BSO. If size is less than 2 cm, no pelvic lymph node dissection. If size is 2 cm or more than 2 cm, pelvic lymph node dissection. 1A grade 3 and 1B. 1A grade 3 and 1B. TAH plus BSO plus pelvic lymph node dissection plus post-op radiotherapy. Stage 2, Vardheim hysterectomy with pelvic and para-aortic lymph node dissection post-op radiotherapy. 3 and 4, debulking surgery. Pelvic and para-aortic lymph node dissection, of course, in debulking surgery, followed by chemoradiation. So 3 and 4, chemoradiation. Which one is radiosensitive drug? Cisplatin. Cisplatin. So this much is enough for endometrial cancer. Let's move to obstetrics. Placenta. Placenta is formed by chorion frondosum and decidua basalis. How much is the weight of term placenta? 500 gram. Weight of term uterus? 1000 gram. Term placenta 500, term uterus 1000 gram. Weight of placenta is to baby 1:6. Length of umbilical cord is 3200. Mean length is 55. It has 2 arteries and 1 vein. Very simple. So length is 3200. Length of umbilical cord is 3200. And weight of term uterus is 1000 gram. Weight of term placenta is 500 gram. Fine. Amniotic fluid pH is 7 to 7.5 is the wide range. Shorter range 7.2 to 7.4. Specific gravity 1.008 to 1.010. Volume at 12 weeks not important, 50 ml. This is important. Maximum volume of amniotic fluid is at 32 to 34 weeks, and out of these two, which one is best answer? 32 we have clearly written in our note. So amniotic fluid is maximum at how many weeks? 32 weeks. If 32 is not given in option, between 32 to 34. At term, not very important. Only question will be maximum amniotic fluid. Rate of amniotic fluid turnover. Rate of amniotic fluid turnover is 500 cc per hour. Osmolality is 250 milliosmol per liter. So pH is 7.2 to 7.4. pH is 7.2 to 7.4. In our notes, we have clearly written 7.2 to 7.4, although wider range is 7 to 7.5. Specific gravity 1.008 to 1.010. Fine. Only question here will be, which I take, maximum amount of amniotic fluid is seen at 32 weeks. Here. Color of amniotic fluid, if the question asked is color of amniotic fluid, colorless. Early pregnancy, colorless. Term pregnancy, pale straw. So it is colorless. Pale straw at term pregnancy. Color of amniotic fluid is green in listeria infection, breech, transverse and fetal distress. Greenish yellow, that is saffron colored. Greenish yellow saffron colored is in post-term pregnancy. New name is post-term pregnancy. Golden yellow is seen in RH negative. Golden yellow is seen as RH incompatibility. Golden yellow RH incompatibility. Greenish yellow post-term. Post-term. Tobacco juice like. Tobacco juice dark brown intrauterine fetal demise. Dark colored amniotic fluid is seen in concealed hemorrhage. So dark colored abruptio placentae. Dark colored abruptio placentae, particularly in concealed. Intrauterine fetal demise, color of amniotic fluid, tobacco juice, dark brown. RH incompatibility, golden yellow. RH incompatibility, golden yellow. Post-term, saffron. Post-term, saffron. Listeria breech transverse fetal distress, green. Listeria breech transverse fetal distress, green. Term pregnancy, pale. Or otherwise, color of amniotic fluid is colorless. Color of amniotic fluid is colorless. Now, periods in pregnancy. Ovular period, fertilization to 2 weeks. Embryonic period, 3 to 8. 3 to 8. Fetal period, 9 weeks onward. Fetal period, 9 weeks onward. Trimester. First trimester is up to. First trimester is up to. Best answer is up to 14. What we have written in note. Second is after 14 to completion of 28. Third is after 28 to 42. That's what Williams says. If not given in option, we will follow DC Datta obstetric. What you have to remember here is duration of pregnancy is how many days? 280 days. Duration of pregnancy is how many days? 280 days. True conceptional period is how many days? 266 days. True conceptional period is calculated from which? From day of fertilization. Period of amenorrhea or duration of pregnancy is calculated from first day of last menstrual period. What is early term? Come on everyone. Early term, 37 weeks to 38 weeks, 6 days. Term is 39 to 40 weeks, 6 days. Late term is Late term is 41 weeks to 41 weeks, 6 days. Post term is 42 or more than 42. Post term is 42 or more than 42. Come on. So don't commit any mistake in true conceptional period or period of amenorrhea. Best test to detect pregnancy. Fluoroimmunoassay. Fluoroimmunoassay. It can pick up how much HCG? 0.001. Radioimmunoassay how much? 0.002. And this is the test which can detect pregnancy 7 days after fertilization. So if it is a regular 28-day cycle, these blood tests, fluoroimmunoassay and radioimmunoassay, can diagnose pregnancy how many days before she is overdue? 7 days before she is overdue. How many days before she is overdue? 7 days before she is overdue. So, earliest test to diagnose pregnancy is urine pregnancy test. It detects pregnancy on first day of missed period. Most common test, first investigation to diagnose pregnancy is urine pregnancy test. First investigation to diagnose pregnancy is urine pregnancy test. Best test to diagnose pregnancy is blood test. It can diagnose pregnancy how many days before she is overdue in a regular cycle? 7 days before she is overdue in a regular cycle. Best sample for urine pregnancy test is early morning sample. Early morning. Important question, HCG is secreted by syncytotrophoblast and examiner is ready to trap you with cytotrophoblast. Examiner is ready to trap you with cytotrophoblast. HCG is secreted by what? Syncytotrophoblast. HCG levels are maximum at 10 weeks of pregnancy. 10 weeks. They are minimum at 16 weeks of pregnancy. 3 chocolate questions of HCG. Maximum at 10 weeks. Minimum at 16 weeks. HCG disappears from circulation 2 weeks after delivery. And HCG doubles every 48 hours. So doubling time of HCG is 48 hours. Fundal height. At 12 weeks, uterus is at what level? At 12 weeks, it is at the level of pubic symphysis. 16 weeks, midway between pubic symphysis and umbilical. 24 weeks, upper border of umbilical. If nothing is mentioned about umbilical border, then answer is 24. 28 weeks, junction of upper 2/3 and lower 1/3. 28 weeks, junction of upper 2/3 and lower 1/3 between the sternum and umbilical. So from umbilicus, it is 1/3. 32 weeks, junction of upper 1/3 and lower 2/3. Junction of upper 1/3 and lower 2/3. 36 weeks, it is at the level of Ziphis sternum. It is at the level of Ziphis sternum. Fine. Then 40 weeks at 32 weeks level. Important MCQ here. How to differentiate 40 with 32? How to differentiate 40 with 32? At 40 weeks, head will not be palpable. They are at the same level. 40 weeks, head will not be palpable, while at 32 weeks, head will be palpable. This is how we differentiate. So, few questions here. Few questions here quickly. That's important. Best clinical method for assessment of gestational age is? Best clinical method for assessment of gestational age is fundal height estimation. Best method for assessment of gestational age is? Best method for assessment of gestational age is ultrasound. Best clinical sign of pregnancy. Best clinical sign of pregnancy is auscultation of fetal heart sound. Best sign of pregnancy. Best sign of pregnancy is visualization of cardiac activity by ultrasound. So don't commit any mistake. First investigation of to diagnose pregnancy, urine pregnancy test. Best investigation, fluoroimmunoassay. It can diagnose pregnancy how many days before overdue? 7 days before she is overdue. True conceptional period, 266 days. 266 days. Period of amenorrhea, 280 days. True conceptional period, that is ovular period or embryonal period or fetal period, they are 2 weeks less than period of amenorrhea. So if period of amenorrhea is 10 weeks, how many weeks period is this? Period of pregnancy, they are 2 weeks less because periods of pregnancy are calculated from day of fertilization. So period of amenorrhea 10 weeks, how many fetal growth weeks or how many true conceptional weeks? 8 weeks. So true conceptional age is 2 weeks less because it is calculated from day of fertilization. So don't commit any mistake. 12 weeks period of amenorrhea. 12 weeks period of amenorrhea. How many weeks period of pregnancy? 10 weeks period of pregnancy. So they are less. Fine. So fetal age is 2 weeks less. Don't commit any mistake in that. That is a trap zone here. Then clinical sign, overall best sign. Pseudocysis is a pseudo pregnancy. All absolute signs of pregnancy will be absent in pseudocysis. Most common treatment of postpartum blue. Treatment of postpartum blue, reassurance. Treatment of postpartum depression, fluoxetine. Treatment of postpartum psychosis, antipsychotic drug. If you are dealing with any question related to uterine rupture, fetal bradycardia, fetal bradycardia, and fetal parts are easily palpable. Uterine dehiscence, fetal tachycardia. Uterine dehiscence, fetal tachycardia. Uterine rupture, fetal bradycardia, and fetal parts are easily palpable. Management of obstructed labor, immediate cesarean section, no wait and watch, no oxytocin. Because there is risk of uterine rupture, vesico-vaginal fistula, and uterine prolapse. Most common cause of uterine prolapse, mismanaged second stage of labor. So risk with obstructed labor is uterine prolapse. Most common cause of vesico-vaginal fistula in developing country is obstructed labor. So obstructed labor can complicate into vesico-vaginal fistula. So in obstructed labor, no wait and watch, no oxytocin, immediate cesarean section. Bendel's ring or retraction ring is seen in obstructed labor. Mild vaginal bleeding, hematuria, exhausted patient. This ring is present at the junction of upper and lower segment of uterus. Schroeder ring is also called constriction ring, is due to injudicious use of oxytocin. That is seen only vaginally. That is seen only vaginally. So you know Bendel's ring or retraction ring is pathological, while Schroeder ring, which is due to injudicious use of oxytocin, is physiological. That is seen only vaginally. Seen only vaginally. Fine. Let's come back, then we'll discuss various things. Abortions. Most common time for abortion is first trimester. Most common time for abortion is first trimester. Most common cause for second trimester isolated abortion, idiopathic. Most common cause of second trimester recurrent abortion is cervical incompetence. This is very important question. Most common cause of second trimester recurrent abortion, cervical incompetence. Diagnosis of cervical incompetence is by ultrasound. Cervical length less than 2.5 centimeter, internal os diameter more than 2 centimeter. We have clearly written in our note. Cervical length less than 2.5, internal os diameter more than 2 centimeter. McDonald stitches are applied in cervical incompetence. They are applied between 12 to 14 weeks. They are applied between 12 to 14. Most common time for abortion due to cervical incompetence. Most common time of abortion due to cervical incompetence is 16 to 24 weeks. Important question. Most common time for abortion due to cervical incompetence 16 to 24. So McDonald stitches are applied between 12 to 24. Although they can be applied up to 24 weeks. Where else did we write like this up to? Second dose of NTD is given within 72 hours of delivery, but can be given up to 28 days. Second dose of NTD is given if direct Coombs test is negative. First dose of NTD is given if indirect Coombs test is negative. Important question. So how many total doses of NTD? 2. First dose is given antenatally. At how many weeks? 28 weeks of pregnancy. It is given if indirect Coombs test is negative or positive. If indirect Coombs test is negative. Second dose is given if direct Coombs test is negative or positive. It is given if direct Coombs test is negative. So both are given if ICT and DCT are negative. Immediately after delivery, which test is done? Roseate test is done. Roseate test is to detect fetal blood in mother. Negative roseate test means fetal blood in mother is less than 15 ml. If roseate test is negative, what is the next step? Give second dose of anti-D 300 microgram. If roseate test is positive, do a Klehor-Betke test. What is the purpose of Klehor-Betke test? We will take a 15 minutes break just now. After this, we will take a 15 minutes break. If roseate test is positive, we do a Klehor-Betke test. What is the purpose of Klehor-Betke test? To know the exact amount of feto-maternal hemorrhage so that we can calculate the dose of NTD. So Klehor-Betke test is done if roseate test is positive. Purpose of Klehor-Betke test is to calculate exact amount of feto-maternal hemorrhage. Let's take a 15 minutes break. This is 4:06 and we will be back at 4:21. Welcome back. Now, maternal pelvis and fetal skull. थोड़ा सा एबॉर्शन पे बात कर लूँ 2 मिनट. 2 minutes on abortion, only 2 minutes. थोड़े से क्वेश्चन सॉल्व कर लेते हैं क्विकली. Most common time for abortion, first trimester. Maximum abortions before 8 weeks. Blighted ovum and embryonic abortion. Mean sac diameter 25 mm or more than 25 mm and sac is empty, blighted or an embryonic. Missed abortion, embryo CRL 7 mm or more than 7, no cardiac activity. Fine. Threatened abortion, she will complain of mild spotting, mild pain. Fundal height equal to period of amenorrhea. Internal os close, threatened. Management, bed rest, progesterone. Inevitable, fundal height equal to or less than period of amenorrhea. Complaint, pain, bleeding PV. Internal os open. Management, suction evacuation. If more than 12 weeks, add oxytocin. Incomplete abortion, complaint, pain, bleeding PV, and she will give history of expulsion of product of conception. She will say, Doctor, I passed PSAIL. 12th December question, out of this 1 minute. Out of this 1 minute, 12th December question. She will say, I passed PSAIL. So, history of expulsion of products of conception, pain and bleeding. Internal os is open, fundal height is less than period of amenorrhea. This is incomplete abortion, management, suction evacuation. Then missed abortion. She will come to you just for checkup. Fundal height less than period of amenorrhea. Internal os open. Some patients may give dirty brownish blackish dye. Dilatation, evacuation. Most common method of MTP first trimester, medical abortion. Best method of MTP first trimester, suction evacuation. Best method of MTP second trimester, dinoprostone PGE2. Drug of choice for induction of labor, dinoprostone PGE2. Drug of choice for augmentation of labor, oxytocin. Suction evacuation, Carmen's cannula, important MCQ, number of cannula is equivalent to diameter of cannula in millimeter equivalent to weeks of pregnancy. For 8 weeks pregnancy, which number cannula? 8 number. Diameter of 8 number, 8 millimeter. Suction pressure, 400 to 600 millimeter of mercury, 600 best answer. Most common complication of suction evacuation, bleeding. Fine. Don't come. Menstrual regulation syringe, 50 cc syringe. In CCD sessions, I showed MR syringe, MVS syringe in detail. Menstrual regulation syringe, 50 cc syringe. Manual vacuum aspiration syringe, 60 cc syringe. Pressure in manual vacuum aspiration, 660 millimeter of mercury. Fine. So that's enough for abortion. Maternal pelvis and fetal skull. Smallest fetal head diameter is bimastoid. Fine. Smallest fetal head diameter is bimastoid. Chanting karte, let's do chanting as well as quickly. So smallest fetal head diameter is bimastoid. This one. Second smallest is bitemporal, 8 centimeter. Largest fetal head diameter is mentovertical, 14 centimeter. Fine. So smallest fetal head diameter bimastoid. Second smallest bitemporal. Largest is mentovertical. Let me quickly. Largest fetal head diameter. Largest fetal head diameter mentovertical, 14 centimeter. Largest transverse fetal head diameter biparietal, 9.5 centimeter. Smallest fetal head diameter bimastoid, 7.5 centimeter. Most common transverse engaging diameter of fetal head biparietal, 9.5 centimeter. Most common longitudinal engaging diameter of fetal head suboccipitobrachmatic, 9.5 centimeter. Longest engaging diameter of fetal skull mentovertical, 14 centimeter. If longitudinal engaging diameter is mentovertical, what is the presenting part? Bro. Presenting part is bro. So if presenting part is bro, what is the management? Caesarean section. So don't commit any mistake. Most common longitudinal engaging diameter suboccipitobrachmatic, 9.5. Most common transverse engaging diameter biparietal 9.5. Largest diameter of fetal skull mentovertical. Largest longitudinal engaging diameter of fetal skull mentovertical. How much it is? 14 centimeter. Come on. Clinically measured conjugate. Now we are talking about pelvis. Clinically measured conjugate is diagonal. Diagonal conjugate. Smallest and most significant conjugate of inlet obstetric. Let me quickly explain you, then we will be able to solve these. So, in 1 minute, I am revising all diameters of pelvis. 1 minute. Inlet mid pelvis outlet. Inlet anterior posterior 3. True conjugate, obstetric conjugate, diagonal. All three from midpoint, upper margin, sacral promontory to upper border of pubic symphysis, true, 11 centimeter. Mid pubic symphysis, obstetric conjugate, 10 to 10.5. Up to lower border of pubic symphysis, diagonal 12. Transverse of inlet between two farthest points on iliopectineal line, 13. AP of mid pelvis from lower border of pubic symphysis to junction of S45. This is MCQ. To junction of S45, 11.5. Transverse of mid pelvis between two ischial spines, interspinous or bispinous, 10 centimeter. AP of outlet from lower border of pubic symphysis to tip of coccyx. AP, anatomical AP 11.5, obstetric AP at the time of delivery of head may reach up to 13. Transverse of outlet between two ischial tuberosity, intertuberous or bituberous, 11 centimeter. Important question. Most important diameter of pelvis, interspinous 10 centimeter. Smallest diameter of pelvis, interspinous 10 centimeter. Smallest diameter of pelvic inlet, obstetric conjugate 10 to 10.5. Most important or diameter of pelvic inlet, obstetric conjugate 10 to 10.5. Which conjugate can be measured clinically? Diagonal conjugate. Oblique conjugate of inlet from sacroiliac joint on one side to iliopubic eminence on opposite side, 12 centimeter. Right oblique starts from right SI joint, left oblique starts from left SI joint. Let's come back to all in one. Smallest and most significant of inlet, obstetric. Smallest transverse diameter oval or interspinal. It is at mid pelvis. Most important diameter of pelvis, interspinal. Most common type of pelvis, gynecoid. Deep transverse arrest. Persistent occipito-posterior positions, android pelvis. Prominent ischial spine, android pelvis. Heart-shaped pelvis, android pelvis. Fore pelvis is much smaller than hind pelvis, android pelvis. Face to pubis delivery, direct occipito-posterior, anthropoid pelvis. Most common cause of non-engagement, CPD, although not very specific. No MCQ will be asked. Best clinical method to diagnose CPD, trial of labor. Best investigation to diagnose CPD, MRI. Most common presentation, cephalic. Most common position, left occipito transfer or left occipito anterior. Just quickly in 2 minutes, few MCQs. Most common presentation is cephalic. Most common presenting part is vertex. Most common denominator is occipit. Most common attitude is attitude of flexion. Station is the relationship between presenting part and ischial spine. 0 station at ischial spine, below plus, above minus. Position relationship between denominator and pelvis. Most common position, left occipito transfer. If the question is most common position in late labor, and if you have to choose between LOT and LOA, LOA. If you have to choose between LOA and DOA, DOA. Fine. So these are few important things which may be asked, and you should know how to identify if we are doing PV, how to identify whether the presenting part is vertex, bro or face. So denominator in vertex is occipit. So if I am doing PV and my fingers touch occipit, vertex. I am doing PV, my fingers touch supraorbital ridges, presenting part is pro. I am doing PV, my fingers touch this chin or mentum, presenting part is face. So denominator in face, chin or mentum. I am doing PV, my fingers touch mentum or chin, face. I am doing PV, my fingers touch supraorbital ridge, presenting part is bro. I am doing PV, my fingers touch vertex, presenting part is, my fingers touch occiput, presenting part is vertex. So most common presentation, cephalic. Most common presenting part, vertex. Most common denominator, occiput. Most common attitude, attitude of flexion. Most common position, left occipital transfer. Most common position in late labor, left occipital anterior followed by direct occipital anterior. Which conjugate can be measured clinically? Which conjugate can be measured clinically? Diagonal conjugate. Sure. Quickly. Labor. What are the indications of early cord clamping? Indications of early cord clamping, RH incompatibility, if she is having hypoxia, if the neonate is having hypoxia or asphyxia, if neonate has heart disease, or in HIV according to National AIDS Control Program. Fine. So, what are the indications of early cord clamping? RH incompatibility, if there is asphyxia or if there is heart disease in neonate. What is the method to deliver placenta? Modified Brand and Reuse technique. Abdominal sign of placental separation, change in consistency of uterus, firm globular. Vaginal sign of placental separation, gush of blood, permanent lengthening of vagina and placenta in vagina. Best drug for induction of labor, PGE2. Best prostaglandin for medical abortion, misoprostol, PGE1. And drug of choice for augmentation of labor is oxytocin. So abdominal sign of placental separation, change in consistency of uterus. It will become firm globular. Vaginal sign of placental separation, gush of blood, placenta in vagina, and permanent lengthening of umbilical cord. What are the contraindications of oxytocin? Twin pregnancy before delivery of second twin, hypertension, heart disease, and Rh negative. These are contraindications of oxytocin. Best method of recording progress of labor is partogram. Best method to assess progress of labor, partogram. What is plotted on x-axis? Time in hour. What is plotted on y-axis? Cervical dilatation and descent of head in centimeter. Few important questions here. Few important questions. Tell me. Answer me. How much is the time interval between? How much is the time interval between alert line and action line? Alert line and action line. How much is the time interval? 4 hours. If alert line is crossed, what does it indicate? Prolonged labor. If action line is crossed, what does it indicate? Indication for immediate cesarean section. Indication for immediate cesarean section. These three questions are very important. Best method to assess progress of labor, partogram. If alert line is crossed, prolonged labor. If action line is crossed, indication for immediate cesarean section. Very nice, very nice. Very, very good, very good. Come on. Let me quickly discuss labor question. All those labor questions, cervical dilatation 2 centimeters, say when a patient is coming at 6 am, 2 mm, all labor clinical questions I discussed in CCD beautifully. There were 4 questions of labor, clinical questions long. She is coming in labor room at that time with this much dilatation and all. Please do watch. There is a reason why I am saying all these things. Okay, come on. Let me quickly revise in 3 minutes. Latent phase, duration, primi, up to 12 hours, multi up to 8 hours. Delayed latent phase primi, if 20 or more than 20 hours, multi 14 or more than 14 hours. Causes of delayed latent phase, excessive sedation, analgesia given or genetically poor survey. Management of delayed latent phase, therapeutic RAS. Active phase begins at 6 centimeter dilatation. So up to 5 centimeter, it is only latent phase. Active phase begins at 6 centimeter. Rate of cervical dilatation should be at least 1 centimeter per hour. Slow active phase if cervical dilatation is less than 1 centimeter per hour. Arrest of active phase if no cervical dilatation for 4 hours. Question. A patient comes to you with slow active phase. Examiner will write cervical dilatation. You will come to know this is active phase. Slow active phase. What is the next step? Now in this question, examiner may write the word CPD or occipito-posterior. Slow active phase, we have to rule out any CPD or occipito-posterior. If CPD is Caesarean section, if occipito-posterior, wait and watch. If CPD or occipito-posterior not written, then artificial rupture of membrane and oxytocin. If arrest of active phase means no dilatation for 4 hours, written Caesarean section. Then second stage duration in multi up to 30 minutes, in primi up to 1 hour. Delayed second stage, multi double. More than 1 hour, primi more than 2 hours. Management of delayed second stage, what we have to look for. Management of delayed second stage, look for station. If a station is +2 or more than +2, forceps or vacuum. If a station is less than +2, Caesarean section. What is arrest of second stage? Again double. Primi 3 or more than 3 hours, multi 2 or more than 2 hours. Management of arrest of second stage, Caesarean section. Third stage, active management duration 5 to 10 minutes. Passive management duration 15 to 20 minutes. Active management 5 to 10 minutes. Delayed third stage if placenta is not expelled even after 30 minutes. It is also called retained placenta. So management of delayed third stage is manual removal of placenta in operation theatre. Which anesthetic is used? Halothane. So we will solve all the questions related to this, and to solve long questions, please do watch CCD session upload already there in the app. Fine. Bishop's score is for pre-induction cervical assessment. Bishop's score is for pre-induction cervical assessment. It includes cervical dilatation, effacement, consistency, position and station of head. Examiner gives you a question and traps you here. All of the following are component of Bishop's score except. And examiner always trap with position of head. So in Bishop's score, it is station of head. In modified Bishop's score, cervical effacement is replaced with cervical length. Modified Bishop's score, effacement is replaced with length. Maximum score is 15. If 9 or more than 9, induction will be successful. Bendel's ring is seen in obstructed labor. We discussed properly. Preterm labor before 37. Most common cause is idiopathic. Second is infection. Best drug to treat preterm labor, nifedipine. We discussed. We did chanting beautifully. Breech presentation. Occurrence is 3%. Value of this percent is after 34 weeks. Most common cause of breech, prematurity. Most common cause of congenital recurrent breech, congenital malformation of uterus. Most common type of breech, frank breech. Most common position in breech, left sacro-anterior. Bitrochanteric diameter is the engaging diameter of breech, 10 cm. Bisacromial is the engaging diameter of shoulder in breech, 12. Suboccipitofrontal engaging diameter of head in breech. So engaging diameter and engaging diameter of head both are 10 cm. Both are 10 cm. Delivery maneuvers, Pinard's maneuver is for extended legs. Lafsette's maneuver is for extended arm. Burn-Marshall is for head. Cord prolapse maximum with footling and maximum chance of cord prolapse overall is in transverse lie. Let me tell you breech in 2 minutes for examination. Breech two types, complete or incomplete. Complete is thighs are flexed and knee are also flexed. Complete breech is also called flexed breech. What is palpable? PV finding in complete breech or flexed breech. PV finding are buttocks, genitalia and feet. Incomplete breech three types. Most common is frank or extended. Thighs flexed, knee extended. PV finding buttocks, genitalia. Knee breech. Thigh extended, knee flexed. PV finding knee. Footling breech. Thigh extended, knee extended. PV finding is feet. Most common breech overall, frank breech or extended breech. Assisted breech delivery can be tried in frank breech and flexed breech. Method to remove extended legs, to deliver extended leg. Pinard's maneuver. What is praised? Popliteal fossa. Maneuver to deliver extended arms. Lafsette's maneuver. Maneuver to deliver after coming head. Burn-Marshall. Overall best maneuver to deliver after coming head. Piper's forceps. Postterm pregnancy. Postterm pregnancy, postterm is 42 or beyond 42. Postterm is 42 or beyond 42. Now, this is the old criteria. So we know postterm is 42 or beyond 42. That is the postterm. Most common cause for postterm is mistaken dates. And what is the first step in diagnosis? Review her menstrual history again. Congenital abnormality mostly associated with postterm is anencephaly. Congenital abnormality mostly associated with postterm is anencephaly. Anencephaly. Now, ectopic pregnancy. Most common site of ectopic, ampulla. Most common site of tubal abortion, ampulla. Most common or earliest site of tubal rupture is stomach. Most common cause is PID. Symptoms of ectopic pregnancy, most common symptom is lower abdominal pain. Most common symptom of ectopic, lower abdominal pain. Most common symptom of PID, lower abdominal pain. How to differentiate? Urine test will be positive for pregnancy in ectopic pregnancy. Gold standard diagnosis is laparoscopy. Investigation of choice is transvaginal sonography plus beta HCG correlation. Once again, in 2 minutes for examination. Examination question. Ectopic pregnancy, patient coming, medical management or expectant or surgical. Beta HCG less than 1000, expectant. 1000 to 5000, ectopic mass size less than 4 cm, cardiac activity absent, medical management methotrexate. 50 mg per meter square body surface area. HCG more than 5000, mass size more than 4 cm, cardiac activity present or no response to medical management surgery. Exam question 12 December already uploaded in computer by NB. I am assuming. I don't know anything. Question is, there may be 2 or 3 questions. Amenorrhea, she missed her period. Urine pregnancy test positive, uterus is empty, so this is ectopic. Now, HCG values might be written there, mass size might be written, cardiac activity status might be written. You will choose. If surgical management is chosen, means that HCG is high, mass size is more, cardiac activity is present, then which surgery? Examiner will trap here. Laparotomy or laparoscopy? If everything is fine, laparoscopy. In laparoscopy, salpingostomy, ostomy, clear. If hemodynamically unstable, means ruptured pregnancy. So what he will write, either in shock or hemodynamically unstable or BP is falling. That is ruptured ectopic pregnancy or pain in shoulder, then fourth sign. So ruptured ectopic pregnancy, laparotomy. Laparotomy, salpingectomy. Whether unruptured or whether ruptured. No oophorectomy. Ovaries are not removed. That's all. Come on. Pregnancy-induced hypertension, PIH. Best indicator of PIH is hypertension. Hypertension plus proteinuria, best is hypertension. End organ damage occurs in severe, not in mild. HELLP syndrome is a complication of severe preeclampsia. Drug of choice for PIH is labetalol. Eclampsia is severe preeclampsia plus seizure. Antepartum eclampsia, worst prognosis. Most common eclampsia antepartum, worst prognosis antepartum. First step is maintenance of airway, then magnesium sulfate. Name of rezyme is Pritchard rezyme. And safe therapeutic level of magnesium sulfate is 4 to 7 MEq per liter. We discussed PIH, mild PIH 37, severe 34, HELLP syndrome eclampsia, immediate induction of labor as soon as it occurs, as soon as we have diagnosed HELLP syndrome or eclampsia. Eclampsia here, most common eclampsia antepartum, worst prognosis of eclampsia also antepartum. Most common eclampsia, antepartum eclampsia. Worst prognosis in eclampsia, antepartum eclampsia. All drug of choice, everything we have discussed. First sign of magnesium sulfate toxicity is disappearance of knee jerk. First sign of magnesium sulfate toxicity is disappearance of knee jerk. What is the antidote of magnesium sulfate poisoning? Antidote of magnesium sulfate toxicity, 10 ml 10% IV calcium gluconate. 10 ml 10% IV calcium gluconate. Earliest sign of magnesium sulfate toxicity is disappearance of knee jerk. Whenever a patient enters your chamber with eclampsia, that is with seizure, first step is maintenance of airway. Second step is to give her magnesium sulfate. So don't commit any mistake here. Fine. Twins. What is Helen's rule? Helen's rule is to define incidence of twins. I am proud of you, all my loving students. How actively are you participating? I will see everything at the end of the session. I really admire and proud of all of you. Oh my God, what's happening? What's happening? My God, my God. So proud of you. All of you 200 plus. Twins 1 in 80, Helen's rule. Twins 1 in 80. So happy to see. Triplets 1 in 80 square, quadruplets 1 in 80 cube. So Helen's rule is for incidence of twin. Then important question area, timing, variety of monozygotic twin. It depends on timing of division. If division within 72 hours, dichorionic diamniotic. If division occurring between 4 to 8 days, monochorionic diamniotic. If it is occurring between 9 to 12 days, mono. And if division occurs after 12 days, that is conjoined twins or Siamese twins. Worst prognosis overall is seen with conjoined twins. Conjoined twins are also called Siamese twins. Most common conjoined twins are paraphagous. Most common, we have written in our notes, paraphagous, followed by second most common, thoracophagous. So most common laterally joined, paraphagous, and second most common are thoracophagous. Most common complication of monochorionic diamniotic is twin-twin transfusion syndrome. Most common complication of monochorionic diamniotic, twin-twin transfusion syndrome. Most common complication of monochorionic monoamniotic, cord entanglement. Most common complication of monochorionic monoamniotic, cord entanglement. Most common complication of monochorionic diamniotic, twin-twin transfusion syndrome. Staging in twin-twin transfusion syndrome, quintro staging. Staging in twin-twin transfusion syndrome is क्विंट्रो स्टेजिंग. क्विंट्रो स्टेजिंग, स्टेजिंग से थोड़ा थोड़ा याद आ रहा है कुछ क्वेश्चन, दोज आर वेरी इंपॉर्टेंट. Most common site of metastasis in choriocarcinoma, lung. If lungs are involved in choriocarcinoma, stage is 3. If vagina is involved with endometrial cancer, stage is 3B. If vagina is involved with endometrial cancer, stage is 3B. So don't commit any mistake in all these things. Hydronephrosis or hydroureter with cancer cervix, 3B. Inguinal lymphadenopathy with cancer cervix, 4B. 4B. Pelvic lymph nodes with cancer cervix, 3C1. Para-aortic lymph nodes with cancer cervix, 3C2. Ascites with cancer endometrium, 3A. Vagina involved with endometrial cancer, 3B. So be very careful in reading the question. Most common presentation of twin pregnancy. Most common presentation of twin pregnancy, both are cephalic. Very nice. Both cephalic. And second most common, first cephalic, second breed. Commonest maternal complication of twins, very important question, postpartum hemorrhage. Commonest neonatal complication of twins, very important question, prematurity. Relation of different part of fetus to one another is called fetal attitude. Few things. Let us discuss few things. Thumb rule in management of twin pregnancy. If first fetus is non-cephalic, always do cesarean. The question is, first fetus in breech, second is cephalic. What is the next step? Cesarean section. Most common presentation, both are cephalic. Second most common, first cephalic, second breech. Other possibility, first cephalic, second transfer. How to manage first cephalic, second transfer? Second transfer is taken out by internal podalic version. Internal podalic version is also called breech extraction. It is done in operation theatre under general anesthesia. Anesthetic of choice is halothane. What is the risk with internal podolytic version, which is also called breech extraction, uterine rupture? Risk with manual removal of placenta is also uterine rupture. Fine. Discordant twins if difference in fetal weight more than. Discordant twins if fetal weight. Yes, yes, Rachna, you're right. Yes, Sanshila, you're right. Yeah, yeah, yes, Isha, good. Yes, Sheikh, good. Yes, Vikas, yes. Yes, Akash, very nice. Yes, Srishti, yes, Muzammil, yes, Abhirami, very nice. Yes, Anuj, yes, Aruna. So proud of all of you. See, discordant twins if difference in fetal weight is more than 20%. Concordant twins if difference in fetal weight is less than 20%. Other important question area: superfecundation, superfetation. Superfecundation is fertilization of two ova in same cycle by different act of intercourse. Superfetation, fertilization of two ova in different cycle. So if different cycle is written, superfetation. Same cycle, two acts of intercourse, superfecundation. Then complication of twin pregnancy, maternal complication, neonatal complication. Management of twin if first fetus is non-cephalic, always do cesarean section. Always do cesarean section. Most common complication of monochorionic diamniotic twin-twin transfusion syndrome. In twin-twin transfusion syndrome, which fetus has good prognosis? Donor has good prognosis. Smaller has good prognosis. Larger one, recipient has bad prognosis. Larger one develops polycythemia, develops polyhydramnios around it. Fine. So it dies of high cardiac output failure. A smaller one will die due to renal failure. Management of twin-twin transfusion syndrome, laser ablation of abnormal anastomosis. Laser ablation of abnormal anastomosis. Sure. Placenta previa. Stallworthy sign is seen in posterior placenta previa. Posterior, type 2. It is slowing of fetal heart rate on pressing head down into pelvis. We know. So, Stallworthy sign, slowing of fetal heart rate. Slowing of fetal heart rate. Seen in type 2 posterior, type 3 posterior, type 4 posterior. Type 2 posterior on what? Stallworthy sign. Slowing of fetal heart rate when we press head in pelvis. And heart rate becomes normal when pressure is released. Sudden onset, painless, causeless, recurrent, bright bleeding, massive bleeding, preceded by a small warning hemorrhage. Investigation of choice is ultrasonography. If less than 37, expectant management. Expectant management regime is McAfee and Johnson regime. McAfee and Johnson regime. If more than 37 and in labor, active management. So active management is done if 37 or more than 37, if there are gross congenital malformation, if massive bleeding, if there is fetal distress. Fine. Expectant management is done if less than 37 weeks but hemodynamically stable, no gross congenital malformation, no fetal distress, no massive bleeding PV. Expectant management regime is called McAfee and Johnson regime. Bed rest, steroids, tocolytics if required, and if she is RH negative, then we give NTT. Fine. So in any MCQ related to placenta previa, what we have to look for, there will be bleeding per vaginum. Bleeding will stop. We nicely discussed in clinical case discussion. Bleeding will stop because it is recurrent bleeding. Fine. No pain will be there. No pain will be there. So uterus will be soft and non-tender. Uterus will be soft and non-tender. Abruptio placentae question, hypertension, trauma, or some risk factor. It is with cause. Placenta previa causeless. So that will be with cause, some risk factor. Then abdominal pain. Then uterus is hard and tender. Fetal parts not palpable, fetal heart sound not audible, abruptio placentae. Painless bleeding, uterus is soft and non-tender, placenta previa. Nicely discussed in CCD session. Fine. Abruptio placentae symptoms. Continuous dark red, painful vaginal bleeding. So painful, continuous dark red. Fetal heart sound and fetal parts may not be appreciated. This is abruptio placentae. 12 December question. 3 varieties reveal concealed and mixed. Most common variety is mixed variety. Cavalier uterus may be seen in severe variety of concealed abruption. Vasa previa, fetal blood loss due to filamentous insertion of cord. That we know. Few questions only. Fine. So most common cause of antepartum hemorrhage, abruptio placentae. Most common cause of antepartum hemorrhage is abruptio placentae. Most common variety of abruptio placentae is mixed variety. Three variety: revealed, concealed, and mixed. Most common variety of abruptio placentae, mixed variety. Most common cause of antepartum hemorrhage is abruptio placentae. Abruptio placentae, pain, uterus hard and tender, fetal heart sound not audible, fetal parts not palpable, management, immediate induction of labor. But if DIC has developed, treat DIC first. Name of classification, page classification. Which one is more dangerous? Concealed is more dangerous. Cavalier uterus will be seen in concealed abruptio placentae. Other name of cavalier uterus, uteroplacental apoplexy. Classification in abruptio placentae, page classification. Expectant management, Rezyme in placenta previa, McCarthy and Johnson Rezyme. Pain, less bleeding. Uterus is soft and non-tender. Fetal parts palpable. Fetal heart sound audible. Management of placenta previa, minor degree vaginal delivery, major degree cesarean. Minor degree type 1 and type 2 anterior, major degree type 2 posterior, type 3 and type 4. Fine. Most common indication of suction evacuation is MTP during first trimester. Pressure in suction evacuation 400 to 600. We discussed multiple times today as well. Commonest immediate complication after dilatation, evacuation, suction evacuation, bleeding, hemorrhage. External cephalic version is done in breech and transfer to make cephalic. Best time for external cephalic version 36 weeks. Induction of internal podilic version, transverse lie of second twin. Most common episiotomy performed mediolateral. Pressure in ventus initial is 0.2 kg per square centimeter and optimum is 0.8 kg per square centimeter. Lower segment cesarean section is most commonly done and incidence of rupture with it is 0.5 to 1.5%. So most common indication of suction evacuation, MTP during first trimester. Pressure in suction evacuation 400 to 600. Commonest complication of suction evacuation, hemorrhage. External cephalic version is attempted at what time? 36 weeks. It's attempted at 36 weeks. Initial pressure in ventus 0.2 kg per square centimeter. Optimum pressure in ventus 0.8 kg per square centimeter. How much is the incidence of scar rupture with lower segment cesarean section? 0.5 to 1.5%. 0.5 to 1.5%. Few other MCQs related to this. Angle of episiotomy, I think that will be in miscellaneous points. Let me tell you a few things related to operative obstetrics. Angle of episiotomy, best answer is 60 degree. If 60 degree is not given in option, 45 degree. It should be at least 45 degree. But best answer is angle of episiotomy 60 degree. Which episiotomy is most commonly performed? Mediolateral. Third question. Why mediolateral is performed? What is the advantage of mediolateral? Incision can be extended. That's all. Then, forceps and vacuum. Most important prerequisite for forceps and vacuum, station should be +2 or more than +2. At +2, which forceps are applied? At +2, we apply. What forceps are applied at +2? Low forceps. And at +3 and below, it is outlet forceps. Direction of pull, in notes we wrote otherwise, but we discussed in revision session, TND session, CCD session. So, direction of pull. For low forceps at +2, downward, forward, upward, forward. Outlet forceps, it is already down, +3. So downward is not there in outlet. Forward, upward, forward. Low forceps, downward, because it is +2. Make it down first. Downward, forward, upward, forward. Low forceps. Outlet forceps, forward, upward, forward. Maximum pulse permitted in forceps and vacuum. Maximum pulse permitted in forceps and vacuum are 3. Maximum pulls permitted in forceps and vacuum are 3. If failed after 3 attempts, failed forceps, failed vacuum. Management of failed forceps and failed vacuum is cesarean section. Vacuum is applied at which place? Important question. Vacuum is applied on sagittal suture, 3 centimeter anterior to posterior fontanelle. 3 centimeter anterior to posterior fontanelle. Advantage of vacuum over forceps. Only 6 centimeter cervical dilatation is enough. How much? Only 6 centimeter cervical dilatation is enough. Less maternal injury. No need for anesthesia. No need for lithotomy. Vacuum promotes auto-rotation. Vacuum due to suction. Vacuum promotes auto-rotation. So it is preferred in deep transverse arrest. No need for lithotomy. So vacuum is preferred in heart disease. Fine. Advantage of forceps. Forceps are better in fetal distress. If you get any question, fetus is in distress and station is +2 or more than +2. So definitely you have to choose forceps or vacuum. So which one would you choose? If it is fetal distress, you will not choose vacuum. Instead of vacuum, you will choose forceps because vacuum, you need 6 minutes to reach optimum pressure point from point 2 to point 6. So this is why in fetal distress, what is best? Forceps are best. Forceps, less fetal injury. Less fetal injury. Vacuum is applied on sagittal suture, so it can be used only in vertex, while forceps can be used in other presenting parts also. In forceps, and regarding cesarean section, most common abdominal incision in cesarean section, low transverse fenestrine, cosmetically better. Most common incision, uterine incision in lower segment cesarean section, Kerr incision, Kerr, Kerr incision. Then classical cesarean section, upper segment cesarean section. Absolute indications of cesarean section, contracted pelvis, CPD, transverse bro mentoposterior, type 2 posterior, type 3, type 4 placenta previa. Indications of classical cesarean section, dense adhesions in lower segment, type 4 placenta previa, or treated case of vesicovaginal fistula, large cervical fibroid, and post-mortem. Then, two important questions. Risk of scar rupture with lower segment cesarean section, 0.5 to 1.5%. 0.5 to 1.5%. Risk of scar rupture with classical cesarean section, 4 to 9. Important question. How much is the risk of scar rupture with lower segment cesarean section? 0.5 to 1.5%. 0.5 to 1.5%. How much is the risk of scar rupture with upper segment cesarean section or classical cesarean section? 4 to 9%. 4 to 9%. Risk of scar rupture with classical, 4 to 9%. Risk of scar rupture with lower segment cesarean section, 0.5 to 1.5%. Name of incision. Abdominal incision in lower segment cesarean section, low transverse or fenestrine incision. Name of incision in lower segment cesarean section, uterine incision, Kerr incision. Abdominal wall incision, fenestrine incision. Uterine incision, Kerr incision. Kerr incision. Fine. And VBAC, vaginal birth after cesarean, is tried in one previous lower segment cesarean section. Most important prognostic factor for successful VBAC, history of previous VBAC. Means after cesarean section, if one vaginal delivery took place smoothly, that is the best prognostic indicator for VBAC. Best clinical method to diagnose CPD, trial of labor. Best method to diagnose CPD, MRI. Best method to diagnose contracted pelvis, MRI. Management of contracted pelvis, cesarean section. Trial of labor can be successful only in which CPD? Mild inlet CPD. Only in which CPD? Mild inlet CPD. Contracted pelvis, congenitally contracted pelvis, Niggles and Roberts. One LI absent, Niggles. Both LI absent, Roberts. One LI absent, Niggles. Very good, very good. Answering everything. Answering everything. So proud of you. One LI absent, Niggles. Both LI absent, Roberts. Bean-shaped pelvis. Come on, speak out. Answer. Bean-shaped pelvis or reniform pelvis is seen in. Bean-shaped pelvis or reniform pelvis is seen in. My God. Severe rickets in children. Rickets. Mobile is flooded with rickets. Severe rickets in children. Triradiate pelvis is seen in. Triradiate pelvis is seen in. Triradiate pelvis is seen in. Osteomalacia in adults. Triradiate osteomalacia in adults. Bean-shaped or reniform severe rickets in children. Nicholas pelvis, one ella absent. Robert's pelvis, both ella absent. So wonderful. So proud of all of you. मतलब, whenever I am coming to your town, wherever you are, wherever I visit, we will have good chocolate party. We will order chocolate cartoons there. So many chocolates are due for me. A big chocolate party. Not only chocolate party, big party. We will celebrate. We will celebrate like anything. Fine. Let's come back. Okay. Done. Miscellaneous points. मजा आ रहा है. Good. I will come to Tamil Nadu also. I will come to Tamil Nadu. Definitely. Yes, I will come to Gujarat. Yeah, okay. Yeah. Hyderabad also. Yes, definitely. Aha, Udaipur. Okay. Jaipur. Everywhere. Ahmedabad, Surat. Kashmir. पार्टी डन थोड़ा सा और बस थोड़ा सा और लिटिल मोर genetic variant of hydatidiform mole is 46XX. Important question. Most common chromosomal configuration of hydatidiform mole 46XX. Tell me most common chromosomal configuration of partial mole. Tell me most common chromosomal configuration of partial mole. Come on! 12th December, Amritsar also. Yes. Tell me, chromosomal configuration of partial mole. 69, $4. 69XXY. Partial mole 69XXY. Complete mole or hydatidiform mole 46XX. 12th December, question chocolate one. 46XX complete mole, 46XX complete mole, 69XXY partial mole, 69XXY partial mole. Come on. 52 years old female with amenorrhea. 52 years female. 12th December question. 52 years old female with amenorrhea. True it. Increased FSH low estrogen, increased LH low progesterone. So increased FSH and LH, increased FSH and LH, low estrogen and progesterone. Estrogen, progesterone low, ovary failing. FSH, LH high. 12th December chocolate question. Good. How many MTP procedures should be assisted before performing MTP? MTP है. Independently performed 5 and assisted 25. How many cases? Assisted 25 and independently performed 5. Independently performed 5. Assisted 25. Out of that, independently performed 5. License is given by whom? CMO. Chief Medical Officer of the district. Highest failure rate is spermicidal contraceptive. Discussed in PSM. 50 gram glucose for GCT in pregnancy for diagnosis of diabetes. After 1 hour, cutoff is 140. We know that. After 28 weeks of pregnancy, major contributor of amniotic fluid is fetal urine. Overall major contributor of amniotic fluid is also fetal urine. Indomethacin given in the last phase of pregnancy causes premature closure of ductus arteriosus. So it should not be used beyond 32 weeks. So indomethacin causes oligohydramnios. Indomethacin is the treatment of polyhydramnios. EDD is calculated by which formula? Niggles formula. And we know what precautions have to be taken. If cycle length is longer, add the days. If cycle length is shorter, subtract the days. Division of ovum within 3 days will cause diamniotic dichorionic. 4 to 8 days, monochorionic diamniotic. 9 to 12 days, monochorionic monoamniotic. After 12 days, Siamese twins. Conservative treatment for pelvic organ prolapses, pessary. We discussed everything. We will not waste time now again. Most common earliest site of rupture, isthmus, ectopic done. Caesarean, which fibroid can be removed easily? Subserous. Subserous. In caesarean section, which fibroid can be removed easily? During caesarean. Subserous, not submucous. Most common strain causing cervical cancer is 16. Specific is 18. Most common is 16. What is the normal sperm concentration? At least they should be 15 million per annum. We discussed, we chanted. Most common clinical feature in prolactinoma, again we did chanting for this. All those symptoms, amenorrhea, then headache, and then bitemporal hemianopia, everything. Covariate uterus is seen in abruptio. Which variety of abruptio? Concealed variety. Estrogen acts on which parts of breast? We have written in our notes, ducts. And progesterone acts on acini. Important question. Estrogen acts on. Yes, I will come to Shillong also. Thank you so much. Thank you so much for inviting Shillong. Yeah. Estrogen acts on which part of breast? Ducts. Progesterone acts on which part of breast? Acini. Important question. Estrogen acts on ducts. Progesterone acts on acini. Endometrial biopsy can be done in which phase? Post-ovulatory phase. Earliest histological feature of secretory endometrium. Come on, speak out. Earliest histological feature of secretory endometrium. Come on. Histology. Earliest histological feature of secretory endometrium. Important questions. Quickly let's discuss if by chance asked. Earliest histological feature of secretory endometrium, vacuolation. Short tubular gland proliferative. Earliest secretory vacuolation. Late secretory cork, screw or sawtooth. Ultrasound appearance, proliferative endometrium. Come on everyone. Ultrasound appearance. Many messages from unsaved numbers. Actually, when you ask difficulties, I usually save the number so that I know when next time you are asking, or you are able to see my WhatsApp status. That's also the advantage. I try to put good things daily at 9 p.m. See, proliferative endometrium. So is 3-layered or triple-layered or trilaminar endometrium. 3-layered or triple-layered or trilaminar. Secretory phase, hyperechoic endometrium. Good. Fine. Very nice. And please solve daily Telegram questions. I am posting from various subjects now, not only from Obs-Gynae. Till 11th of December, from various subjects I am posting high yield questions. Some of them will be direct on 12th December from various subjects. I'm working hard daily, devoting 2 hours in that only. Till 11th December, I will devote 2 hours daily for that. Fine. So, spontaneous abortion is seen in which genetical condition? Trisomy 16. Yes, we know that. So, most common time for abortion, first trimester. Most common cause of abortion, chromosomal. Aneuploidy, trisomy. Pregnancy but if monosomy X is given, that will be better than trisomy 16. Pregnancy for how many times will be considered as grandparity? 5. Great grandparity 10. Means she has delivered at least 4 times and pregnant for 5th time. Fertilized egg cells are totipotent. Anatomy question, embryology question. It was asked once in MCI. Fertilized egg cells are totipotent. 16-year girl with short height, amenorrhea, widely spaced nipple, Turner syndrome. A lady with 12 weeks pregnancy with bleeding and on examination vagina is normal, internal os is closed. Threatened abortion. We discussed all types of abortion. So we are very clear that these are clinical questions. We will not commit any mistake. Absolute contraindication of IUCD, acute PID. Very simple chocolate question. Angle of cut in episiotomy 60. Angle of cut 60. Which episiotomy commonly preferred? Mediolateral. If 60 is not given in option, second best answer would be 45. Investigation of choice for endometriosis is laparoscopy, but gold standard is histopathology. Investigation of choice for adenomyosis, MRI. Gold standard is hysteroscopic curettage. Dose of mifepristone in emergency contraception 600 milligram. Double decidual sign, radiology sir told you uterine gestational sac. Double decidual sac sign is seen in pregnancy, normal pregnancy due to gestational sac. Late rupture of tubal pregnancy is seen in interstitium. Chocolate question. This is why most dangerous ectopic is interstitial. Most dangerous ectopic interstitial. It ruptures last. Most dangerous ectopic interstitial. Earliest site of rupture of ectopic isthmus. Earliest site of rupture of ectopic isthmus. Most common site of ectopic ampulla. Most common site of tubal abortion ampulla. Most common or earliest site of rupture isthmus. Last site of rupture interstitium. This is why most dangerous ectopic interstitial. Earliest site of rupture isthmus. Earliest site of rupture isthmus. Last site of rupture interstitium. So most dangerous ectopic is interstitial. Most dangerous ectopic is interstitial. Goodell sign at how many weeks? 6 weeks. Chadwick sign at how many weeks? 8 weeks. Earliest sign of pregnancy. Come on. Few question bank. Few question bank for 12 December. Earliest sign of pregnancy, Goodell. Earliest sign is Goodell. Earliest symptom is amenorrhea. Goodell at 6 weeks. Rest of the signs in first trimester, 8 weeks. Which one is bimanual sign? Hagar. Second trimester symptom, quickening. Primary, 18 onwards. Multi, 16 onwards. Second trimester sign, auscultation of fetal heart sound and palpation of fetal part, 18 weeks onward. Third trimester symptom and sign, welcome sign or lightning and reappearance of increased frequency of micturition. Reappearance of increased frequency of micturition. Face, pregnancy sign, pregnancy mask, melasma, chloisma due to increased melanin. Breast 4 changes. Increased size, memogenesis, estrogen, progesterone, estrogen, ductal growth, progesterone, acinar growth, secondary areola, Montgomery tubercle, colostrum, MCQ, how many weeks onward? On squeezing of breast, 12 weeks onward. Abdomen, 2 types of line. Xiphisternum to pubic symphysis, linea alba, linea nigra, blackish brown due to increased melanin. Stria gravidarum, due to dilatation of capillary. After delivery, they are called stria albicans due to obliteration of capillary. After delivery, postpartum discharge, lochia. Correct sequence of lochia. Lochia rubra, lochia alba, lochia rubra, lochia serosa, lochia alba. But before lochia, there is expulsion of placenta. Correct sequence of cardinal movement in second stage of labor. Engagement, descent, flexion, internal rotation, crowning, extension, restitution, external rotation. So correct sequence of cardinal movements in second stage of labor and correct sequence of lochia. Then come back to all in one. Now, Hagar sign is seen at how many weeks? 8 weeks. Braxton Hicks contraction felt at how many weeks? 10 weeks. First definitive sonographic finding to confirm pregnancy is visualization of gestational sac. Best investigation to diagnose fetal age, serial ultrasound. Best time for USG in pregnancy, 18 to 20 weeks. Best ultrasound parameter for gestational age assessment in first trimester and overall also is CRL. Overall best ultrasound parameter for gestational age assessment, CRL. Best ultrasound parameter for gestational age assessment in first trimester is also CRL. In second trimester, it is BPT. For fetal growth, it is abdominal circumference. For third trimester, femur length. So best ultrasound parameter for gestational age assessment overall also is CRL. In first trimester also is CRL. In second trimester, BPD. In second trimester, BPD. For fetal growth or fetal weight. Growth or weight, abdominal circumference. Best ultrasound parameter for assessment in third trimester is femur length. First trimester and overall CRL. Second trimester, BPD. Third trimester, femur length. For fetal growth or fetal weight, abdominal circumference. For PIH, best predictive sign is persistence of diastolic notch in uterine artery beyond 22 to 24 weeks pregnancy. Now tell me please, what is the preventive drug for PIH? Drug for prevention of PIH. Drug for prevention of PIH. Very nice, Sheikh. Very nice. Very nice, Lakshmi. Drug of choice for prevention of PIH. Come on, Akash, good. Shivani, fine. Very nice. Shanur, good. Drug of choice for prevention of PIH. Very good. Aspirin. Drug of choice for prevention of PIH is aspirin. Drug of choice to treat PIH is labetalol. And best predictor of PIH is persistence of diastolic notch in uterine artery beyond 22 to 24 weeks. Amniotic fluid index is good marker for IUGR. Screening test for Down syndrome in first trimester, combined test. These tests, combined test, triple, CVS, amniocentesis, I discussed in CCD session. So in that 3 hours video of CCD, you have 26 long clinical questions with discussion of combined test, triple test, CVS, amniocentesis, ovarian tumor, histopathological findings, and tumor marker. Only those colored highlighted areas have to be read. That's all. And Leopold maneuver also. First, second, third, fourth Leopold maneuver we discussed in that PDF. A screening test for Down syndrome in second trimester, triple and quadruple test. Diagnostic test for Down syndrome in first trimester, CVS. Diagnostic test for Down syndrome in second trimester is amniocentesis. So just remember, screening test for Down syndrome in first trimester, combined test. Definitive test for Down syndrome in first trimester, chorion-villus sampling. Screening test for Down syndrome in second trimester, triple or quadruple. Diagnostic test is amniocentesis, although it is an overlap with pediatrics as well and pathology. Then pseudocholinesterase are raised in abdominal wall defects. Acetylcholinesterase is raised in neural tube defects. Radiology questions actually. Anencephaly can be picked up at 10 weeks, but confirmation at 14 weeks. So earliest congenital anomaly which can be picked up by ultrasound is anencephaly. Down syndrome can be diagnosed at 11 weeks by nuchal translucency. Go through that CCD. Pressure in umbilical artery. Pressure in umbilical artery is 60 millimeter of mercury. Pressure in umbilical artery is 60 millimeter of mercury. Pressure in umbilical vein is 10. Two factual questions, pediatrics discussed in pediatrics. Pressure in umbilical artery, 60 millimeter of mercury. Pressure in umbilical vein, 10 millimeter of mercury. LS ratio is to assess the maturity of lung. Pedia, this is actually. Weight gain in pregnancy, 11 to 12 kg. 11 to 10 to 12, 11 to 12, 11 to 13. So the mean is around 11 to 12. Highly variable. If weight of mother is decreased, so it could be fetal death, it could be due to IUGR. If weight is increased, PIH, edema. Prominent ischial spines are seen in which pelvis? Android pelvis. Most common maternal complication of twins, PPH. We chanted multiple times. Most common fetal complication, prematurity. Doubling time of HCG 2 days, 48 hours. We already did multiple times. Length of term uterus 35 centimeters. These factual anatomy statistics also are given in that PDF. Length of term uterus 35 centimeter. Length of non-gravid uterus 7 centimeter. HELP syndrome is hemolysis, elevated liver enzymes, and low platelets. Most common type of compound presentation is head with hand. Compound presentation when more than one presentation. So most common type of compound presentation, if anything is asked with compound, this is the only question. Most common type of compound presentation is head with hand. Head with hand. Timing for performing amniocentesis 12 to 20, but the best is between 15 to 18. In CCD PDF, best time is 15 to 18. Timing for performing chorion-villus sampling is after 10 weeks. If it is performed earlier, complication is limb reduction syndrome. Now, again, all these decelerations and accelerations are in that PDFs. In CCD, in just 3 hours session, this PDF was also taught. Cause of variable deceleration is cord compression. So, variable deceleration, cord compression. Early deceleration, head compression. Early deceleration, head compression. Variable deceleration, cord compression. Late deceleration, uteroplacental insufficiency. Late deceleration, let me, because that PDF which I posted in WhatsApp groups also. Early deceleration, head compression. Early deceleration, head compression. Late deceleration, seen, this is the only MCQ if at all asked, although the NEET PG is tough. Early deceleration, head compression. Late deceleration, uteroplacental insufficiency. Variable deceleration, cord compression. Persistent variable deceleration, numerous loops of cord around neck. Screening test for Down syndrome. Screening test for aneuploidy in first trimester, combined test. Screening test for aneuploidy in second trimester, quadruple test and triple test. Quadruple is better. Definitive test for diagnosis of aneuploidy in first trimester, choreo and villus sampling. Definitive test for diagnosis of aneuploidy in second trimester, amniocentesis. Early deceleration seen in head compression. Late deceleration, uteroplacental insufficiency. Variable deceleration, cord compression. Persistent variable deceleration, numerous loops of cord around neck. In combined test, just remember one thing, normal nuchal translucency is less than 3 mm. If nuchal translucency is 3 mm or more than 3 mm, it is diagnostic of Down syndrome. It is diagnostic of Down syndrome. Leopold grips, that I will go through that also quickly. After this, I will go through that. Fine. So let me see how much is remaining. Not much. So after that, I'll just quickly come to that PDF. So we'll cover that also within just 30 minutes. Choriocarcinoma is most common after molar pregnancy and most dangerous after full-term pregnancy. Again, important question, John. Choriocarcinoma is most common after molar pregnancy, most dangerous after full-term pregnancy. So most common complication of hydatidiform mole is invasive mole. Most common complication of hydatidiform mole is invasive mole. Most dangerous complication of hydatidiform mole is choriocarcinoma. Choriocarcinoma, and this is different. This is chorioangioma. Chorioangioma is placental tumor. Cause is polyhydramnios. We wrote in polyhydramnios. Chorioangioma, polyhydramnios. Cause of polyhydramnios. Commonest uterine anomaly responsible for abortion is septate uterus. Septate, discussed multiple times. Hematocolpos is collection of blood in vagina. Hematometra in uterus. Hematosalpinx tube. Turner syndrome, one X chromosome is missing. Primary amenorrhea. Short stature, atrophied breast, low. I know nobody will commit mistake in it. Primary amenorrhea with absent axillary and pubic hairs, TFL. Nobody will commit mistake in it. Anticoagulant of choice in pregnancy, heparin. Few words quickly. Important question. Anticoagulation in pregnancy, important. Anticoagulation in pregnancy, first trimester, heparin. After 12 weeks to 36 weeks, warfarin. At 36 weeks, after 36 weeks, again start heparin and stop 24 hours before delivery. Then restart either heparin or warfarin 6 hours after vaginal delivery, 24 hours after cesarean section. Anticoagulation is important in pregnancy, will be asked. Second important thing, contraception in heart disease best is vasectomy. If not willing for vasectomy, then IUCD. Otherwise, if not willing for that also, tubectomy. Which tubectomy? Laparoscopy? No. Mini laparotomy. Best time after 6 weeks. Second best time after the end of 1 week. So don't commit mistake in these questions. Most common congenital malformations. In gestational diabetes, can congenital malformations occur? No. Congenital malformations cannot occur in gestational diabetes, first thing. They occur only in overt diabetes. Okay, if it is overt diabetes, then which one is most common congenital malformation? VST, cardiovascular system. Second is anencephaly, nervous system. Then two other questions. Rare but most specific for gestational diabetes. Rare but most specific for gestational diabetes, caudal regression syndrome or sacrococcygeal agenesis. Most specific cardiac, not most common. Most specific cardiac, TGV, transposition of great vessel. Overall most specific is caudal regression syndrome or sacrococcygeal agenesis. They are specific, but most common is VST. So which system is most commonly involved? Cardiovascular system. Then two very important questions. Best method of diagnosis of congenital malformation, ultrasound. Which ultrasound? TIFFA, radiology sir, TIFFA, targeted imaging for fetal anomalies, which is best done between 18 to 20. You just remember ultrasound. Best method to diagnose, TIFFA ultrasound, TIFFA, Tiffin wala ultrasound, TIFFA. Best method to predict. This is the trap. Best method to predict HbA1c. TIFFA scam. Best method to predict HbA1c glycosylated hemoglobin. To predict HbA1c glycosylated hemoglobin, to diagnose ultrasound, Tiffin wala ultrasound, TIFFA ultrasound, targeted imaging for fetal anomalies. Fine. चलो जी आ जाओ जल्दी से. Let's come back to all in one. Common risk factors for PIHR, we know primary and new paternity, they are responsible, and wherever placenta is more, RH, twin, mole, collagen vascular disease, metabolic X syndrome, APLA syndromes, all written in notes. No, I am not expecting any question. Just remember primary and new paternity. Primary and new paternity. पांचवा बच्चा नए पापा से. So new papa PIH. Diuretics are not preferred in pregnancy due to risk of hypoperfusion. In pregnancy, diuretics are not given, but immediately after delivery, if she is having heart disease. Important question trap. Immediately after delivery, if she is having heart disease, diuretic is given. Why? Because cardiac output is maximum immediately after delivery. So if she is having heart disease, diuretics are given immediately after delivery. So cardiac output is overall maximum immediately after delivery. If written cardiac output is maximum antenatally, then answer will be 32 weeks. Cardiac output is maximum antenatally 32 weeks. Antenatally not written, cardiac output is maximum immediately after delivery. Then what other changes in pregnancy? Let us quickly. Few chocolates questions may be asked. How much is the upliftment of diaphragm in pregnancy? 4 centimeter. Increase in transverse diameter of chest, 2 centimeter. Increase in transverse diameter of chest, 2 centimeter. Increase in chest circumference, 6 centimeter. Subcostal angle in pregnancy becomes 100 to 105 degree. In non-pregnant it is around 65 to 68 degree. So there is widening of subcostal angle. Total lung capacity reduced. Residual volume reduced. Vital capacity, respiratory rate unchanged. Tidal volume increased. How much is the increase of GFR in pregnancy? 50%. How much is the increase of renal length in pregnancy? 1 centimeter. Hydronephrosis and hydroureter, although bilateral, they are more marked towards which side? Right side. Pacemaker of uterine contractions is situated in tubal ostia, more marked towards which side? Right side. Dextrorotation of uterus occurs in pregnancy. What is this sign? Uterus is enlarged more towards right side. What is this sign? Pisca-sex sign. Most common site of interstitial implantation, upper posterior. This is why most common location of placenta is upper posterior, that is fundoposterior. Most common location of placenta, fundoposterior. Pisca-sex sign, dextrorotation of uterus in pregnancy. Hydronephrosis and hydroureter are more marked towards right side. Pacemaker of uterine contraction, tubal ostia, but more marked towards right side. In pregnancy, serum urea, uric acid and creatinine increased or decreased? Write quickly. In pregnancy, serum urea, uric acid and creatinine increased or decreased? In pregnancy, blood में serum, urea, uric acid, creatinine increased or decreased? Decreased. Very nice, decrease. Why? Because GFR is increased, so they are excreted more. In PIH, in pregnancy-induced hypertension, serum urea, uric acid and creatinine increased or decreased? In PIH, they are increased because GFR is reduced. So in normal pregnancy, serum urea, uric acid and creatinine decrease. While in PIH, serum urea, uric acid and creatinine increase. Very nice. Hormones in pregnancy. growth hormone increased, ACTH increased, prolactin increased, aldosterone increased, TSH normal, FSH decreased, LH decreased, DHEA and DHEAS decreased. Again the trap, total hemoglobin in pregnancy increased, total proteins in pregnancy increased, but hemoglobin concentration in pregnancy decreased, protein concentration in pregnancy decreased. Read the question very carefully. Physiological anemia, hemodilution, important chocolate. Physiological anemia, hemoglobin concentration should be at least how much? 11 gram percent. If it is less than 11 gram percent, it will be called pathological anemia. Physiological anemia, it should be at least 11 gram percent. Chocolate question. Cardiac output is maximum immediately after delivery. In pregnancy, in ECG, which axis deviation? Left axis deviation. Left axis deviation. Apex beat in pregnancy, fourth intercostal space, 2.5 centimeter left lateral to mid clavicular line. S1 loud, S2 normal, S3 easily heard. S3 easily heard. Echocardiography finding, mild increase in cardiac silicate because which chamber of heart is increasing? Enlargement of which chamber of heart in pregnancy? Left ventricle. Very nice. Left ventricle. So ejection systolic murmur less than grade 3 is physiological. Less than grade 3 is physiological. Diastolic murmur is pathological. Moderate cardiomegaly in pregnancy, pathological. Severe cardiomegaly in pregnancy, pathological. Mild cardiomegaly is also not very good word. The best word is mild increase in cardiac silicate. If this is not given in option, second best answer will be mild cardiomegaly. This is physiological. All these are physiological. Come on. Let's come back to all in one. Tertiary villi, anatomy ma'am told you, tertiary villi are formed on day 21 post-fertilization. Between day 17 to day 21. So fetoplacental circulation is established on day 17 to day 21 post-fertilization. All ma'am has discussed everything in embryology. Positive whiff test is seen in bacterial vaginosis, but gold standard for bacterial vaginosis is Nugent score. Nugent. Most common site of metastasis in choriocarcinoma, lungs. And what is the stage if lungs are involved? Another important question. 3. If vagina is involved in choriocarcinoma, stage is 2. Stage 1, uterine. Stage 2, fallopian tube, ovary, vagina. Stage 3, lung. Stage 4, brain and liver. Stage 4, brain and liver. Very nice. So proud of you. I will see all the messages after the class. All the messages. All the messages. And if you will save the numbers also if names are written. Theca lutein cysts are seen in molar pregnancy. Theca lutein cysts are seen in molar pregnancy. Important question here. What is the management of theca lutein cysts? Examiner will cook a story. What is the management of theca lutein cyst? Suction evacuation. Suction evacuation. No need to do any surgery for ovarian cyst. Suction, because the culprit is placental tissue. Suction evacuation done, theca lutein cyst will disappear. So management for theca lutein cyst is suction evacuation. Important question. Menopausal female, low estrogen progesterone, increased FSH and LH. Again, important question we discussed multiple times. Breach with foot link, cesarean section. Breach with knee, cesarean section. Transverse cesarean section, important question, just 1 minute, important question. Patient comes in transverse. CCD we discussed a lot. Patient comes in transverse and it is not written that she is labor. She is not in labor. She is not in labor. Transverse. Management is external cephalic version, which is ideally attempted at how many weeks? 36. Question is transverse and she is in labor. Never ever. We have clearly written in our notes. Never ever try external cephalic version. If she comes with transverse and she is in labor, never ever try external cephalic version. Transverse, she is in labor, management will be cesarean section. Management will be cesarean section. Transverse and she is not in labor, external cephalic version. Chalo ji. Most dangerous breach, footling. Most dangerous breach, footling because of maximum risk of cord prolapse. Most dangerous breach, footling because of maximum risk of cord prolapse. Safest breach is frank breach. Safest breach is frank breach or extended breach. Most common breach is frank breach or extended breach. Let's come back. Normal vaginal delivery is best accomplished in twins when both are cephalic. Pressure in first stage of labor 40 to 50. Pressure in second and third stage of labor 100 to 120. Pacemaker for uterine contraction tubal ostia. ये और बता दो जल्दी से. Pain in labor is due to pain in labor. Early labor, which neural segment? T10 to L1. Pain in late labor, S234. Pain in early labor, T10 to L1. Pain in late labor, S234. Most characteristic lesion in PIH in kidney, glomerular endotheliosis. Neat PG question. Most common and worst variety of eclampsia, antepartum eclampsia. Uterine didelphys has two vagina. All other malformations, single vagina. And single fallopian tube in unicornuate uterus. पूरा टॉपिक कई बार चैंटिंग कर लिया. Minimum amount of LH required for ovulation 75 nanogram per ml. FSH-LH ratio in polycystic ovaries is FSH-LH ratio in polycystic ovaries is 1:2. FSH-LH ratio in polycystic ovary 1:2. What is increasing? LH is increasing. Urine frequency increase in first trimester and third trimester. Reappearance of increased frequency in third trimester. BMR rises in pregnancy by 10 to 20%. Rises by 10 to 20%. Zona pellucida prevents multiple sperm entry. Ma'am has taught you in anatomy very well. Zona pellucida prevents multiple sperm entry. So it is protecting ectopic pregnancy also. Cole-Exner bodies are seen in granulosa cell tumor. In our CCD session with that, we discussed all the tumor markers and histopathological finding. Most common presentation of adenomyosis is menorrhagia. Most common presentation of endometriosis is dysmenorrhea. Eclamptic patient with increased intracranial tension, mannitol should be given. Most common site of ectopic pregnancy, ampulla. Most dangerous is interstitial. Cervical fibroid causes retention of urine. Which one? Posterior one. Posterior cervical fibroid causes retention of urine. Anterior cervical fibroid causes increased frequency of micturition. Anterior cervical fibroid causes increased frequency of micturition. Posterior cervical fibroid causes retention of urine. Most prominent part in transverse lie, acromion. Vitamin B6 is given to treat morning sickness. Labetalol is used to decrease BP in eclampsia. Discussed multiple times. Pulsatile GnRH therapy, multiple pregnancies. Maximum incidence is with HMG. Indirect Coombs test is used to detect maternal sensitization in RH incompatibility. First dose of NTD is given at 28 weeks if ICT is negative. So ICT is mandatorily done at 28 weeks. DCT is done after delivery. Strawberry cervix, trichomoniasis. Abortion, death before 20 weeks. Intrauterine fetal demise, death after 20 weeks. Ovaries develop due to absence of SRY. Female external genitalia develop due to absence of dihydrotestosterone. So very simple, we discussed whole embryology. Testis develop due to presence of SRY. Ovaries develop due to absence of SRY. Female external genitalia develop due to absence of DHT. Male external genitalia develop due to presence of DHT. Treatment for CIN2 and CIN3 is sleep. Management of premature rupture of membranes is induction of labor. If DIC occurs in abruptio, first treat DIC, then terminate. Super subparietal transverse engaging diameter, platypaloid pelvis. Today we discussed all this. Maximum insulin resistance pregnancy is between 24 to 28. Maximum is 3 questions, beta, 3 questions. Maximum insulin resistance in pregnancy is between 24 to 28. Insulin resistance in pregnancy begins at 20. Insulin resistance in pregnancy begins at 20. Insulin resistance in pregnancy is maximally due to HPL. If you have to choose single best answer, HPL, human placental lactogen. But estrogen, progesterone and cortisol are also responsible. So if the question is all of the following are causes of insulin resistance in pregnancy except, then HPL, estrogen, progesterone, cortisol will be included. And if you have to choose among all, which one is mostly responsible for insulin resistance in pregnancy, HPL, human placental lactogen, HPL. So insulin resistance starts in pregnancy at 20 weeks. Insulin resistance in pregnancy is maximum between 24 to 28 weeks. 24 to 28. This is why ideal time for GCT according to American College of Gynecology is 24 to 28 weeks. Let's come back. Okay. Deep transverse arrest is most common in which pelvis? Android pelvis. Deep transverse arrest, android. Nigle's formula is to calculate expected date of delivery. During oogenesis, meiosis 1 is arrested in prophase, meiosis 2 in metaphase. Anatomy ma'am taught you oogenesis. Fertilized ovum enters uterine cavity in the form of morula. Zona pellucida prevents polyspermy. Decidual reaction is due to progesterone. Maximum increase in pregnancy is of progesterone. Nitabox membrane prevents morbid adherence of placenta. If Nitabox membrane is absent, it results in morbidly adhered placenta. Accreta, increta, percreta. Accreta if attached to myometrium. Increta invades myometrium. Percreta reaches up to serosa. Accreta attached to myometrium, AA. Attached to myometrium, accreta. Increta invades myometrium. Percreta reaches up to serosa. So there are three types of morbidly adhered placenta: accreta, increta, percreta. Accreta just attached to myometrium. Increta थोड़ा अंदर चला गया, invade. Percreta ज़्यादा अंदर चला गया, up to serosa. So this is prevented by what? Nitabox membrane. Fine. Maternal side of placenta is formed by decidua bacillis, while fetal side is formed by chorion frondosa. What is attached to fetal side? Umbilical cord. What is present on maternal side? Cotyledons. Functional unit of placenta is cotyledons. Fetal reduction is done by potassium chloride. That is for INI-CT stuff. We inject potassium chloride in fetal heart. Rate of amniotic fluid turnover is 500 cc per hour. Most common cause of mild poly is idiopathic. Hofbauer cells are present in placenta. The most common cause of mild oligo, idiopathic. Most common cause of mild poly, idiopathic. Hofbauer cells are present in placenta. Whiten's jelly is present in umbilical cord. Whiten's jelly is present in umbilical cord. Hofbauer cells are present in placenta. Most common cause of mild poly and mild oligo, idiopathic. Severe oligo, maternal hypertension. Severe poly, neural tube defects and gastrointestinal defects. Most common cause of maternal mortality is PPH. Most common cause of most rapid death in obstetrics is postpartum hemorrhage. Indirect, discussed in PSM also, most common indirect cause of maternal mortality, anemia. Maximum risk is due to cardiac failure. Maximum risk due to cardiac failure is immediately after delivery. Cardiac output is maximum immediately after delivery, followed by in labor and followed by 32 weeks. Absolute contraindication of pregnancy is pulmonary hypertension, Marfan syndrome with aortic involvement and coarctation of aorta. Most important parameter in Bishop's score is cervical dilatation. And second important MCQ in modified Bishop's score, cervical effacement is replaced with cervical length. Most important parameter in modified biophysical profile score is AFI. That is modified biophysical profile score. That also is given in that PDF. Ovarian follicle rupture set 20 mm. Chances of progression to frank malignancy in Schroeder's disease, this also we discussed in that PDF. All this is NEET PG stuff actually. This is why I had put it separately in that PDF. Chances of progression to frank malignancy in Schroeder are 1%. Schroeder's disease is metropathia hemorrhagica. I will just discuss that PDF in 20 minutes right now. So the Schroeder's ring is due to injudicious use of oxytocin. So Schroeder's ring is due to injudicious use of oxytocin, while Schroeder's disease is metropathia hemorrhagica. And for treatment of prolapse, we have Shirodkar. They are Shirodkars. Histopathological evidence of proliferative endometrium is pseudostratification. Subserosal fibroid can be removed laparoscopically if it is less than 10 centimeter, while submucous fibroid can be removed hysteroscopically if it is less than 5 centimeter. Intermediate cells are maximum under influence of progesterone. This is maturation index. And now let me quickly, this is how we finish the all-in-one. Quickly let me come back to that PDF. See, so in this, I have already highlighted the important areas. So Leopold maneuvers. There are 4 Leopold maneuvers. 4. First, second, third, fourth. Look here. First is fundal grip. It is to check lie and presentation. Second, we place our hands on either side of maternal abdomen. That PDF I posted in your WhatsApp groups already, 3 days back, I think. So second is we place our palm on either side of maternal abdomen on the day of CCD only, on the day of CCD. And we have to see where is the position and back of fetus. Third is pelvic grip or pollic grip. It is to see whether head is engaged or not. Fourth grip is called second pelvic grip. All this in this PDF is the NEET PG stuff. Just I don't want to take any chance. This is why in 20 minutes we can just go through it. By chance 1% if a question is asked. Fourth is second pelvic grip. Again to see whether head is engaged or not. It is more comfortable for patient. 1, 2 and 3 are done. 1, 2 and 3 are done facing face of the patient. 4 is done, Leopold 4 facing feet of the female. Look here, this is the first grip. This is called fundal grip. First grip is called fundal grip. We place our hands on fundus and it is to see the lie and presentation. Second grip, we place our palm, our hands on either side of abdomen. It is to see where is the back. Where is the back of fetus. Third grip, you can see it is a pelvic grip, also called as pollic grip. Also called, see the position of hand. Position of hand itself tells that we are facing towards the face of the female. It is to see whether the head is engaged or not. Fourth grip is second pelvic grip. Look with the position of our hand, we are facing feet of the patient. Feet of the patient. This fourth grip is also a pelvic grip called second pelvic grip. It is more comfortable for the patient. Pollic grip is third grip. Now, another question, what is the treatment for morning sickness? It is doxylamine plus pyridoxine. Doxylamine plus pyridoxine. Fetal well-being assessment. Assessment, again a NEET PG story. Whether the fetus is safe inside or not. Antepartum, intrapartum. So antepartum fetal heart rate, normal fetal heart rate 110 to 160. I have underlined the area which you can see. 110 to 160, beat to beat variability 5 to 25 beats per minute. Then we ask her to count fetal movements. They are called fetal kick counts. Normal fetal kick count, they should be at least 10 in 2 hours of resting condition, or if she is the office goer, at least 10 in 12 hours of working condition. If fetal movements are sluggish, if they are less than this, it is called sluggish fetal movement. And if they are sluggish, we move to screening test for fetal well-being, and screening test for fetal well-being is modified biophysical profile. This is NST plus AFI, non-stress test. Just remember this, don't go in that detail. And if NST is negative, definitive test is biophysical profile scoring. I have colored it, just remember the name, that's all. No need to, if you don't want to remember, don't remember. Beat to beat variability is 5 to 25 beats per minute. Normal fetal heart rate is 110 to 160 beats per minute. If heart rate is fixed, it is called fixed or sinusoidal, seen in severe fetal anemia, which is seen in RH incompatibility, twin-twin transfusion syndrome, and vasa previa. Nothing. Cardiotocography is NST at labor. If you want to remember, just remember Early deceleration is seen in head compression. Late deceleration is seen in uteroplacental insufficiency, variable in cord compression, persistent variable in numerous loops of cord around neck. That's all. Then diagnosis of aneuploidy, we all in one we discussed these 4 MCQ. Screening test for diagnosis of aneuploidy in first trimester, combined test. Just remember abnormal nuchal thickness is 3 mm or more than 3 mm. That's all. Definitive test in first trimester, chorion villus sampling. Then second trimester, screening test, quadruple and triple. They all are discussed in pediatrics also, I know. So quadruple. Definitive is amniocentesis. Amniocentesis, important question. Amniocentesis is superior to chorion villus sampling because amniocentesis can diagnose neural tube defects also. Then anatomy, I have given some points here, which you know, ma'am has discussed all this, anti-version, anti-flexion, everything. But few things which I would like you, if not discussed in anatomy, then just don't forget this. Just don't forget this one. One is Bartholinitis. Bartholinitis, most common cause is E. coli. If E. coli is not given in option, gonorrhea. Management for Bartholin cyst, marsupialization. For Bartholin abscess, incision and drainage. And you should know these pictures. The swelling here is Bartholin cyst. This is Bartholin cyst and this is the abscess. You can see. This is the abscess. This is the abscess. It is not cyst. It is the abscess. So identify, you should know this is Bartholin abscess and this is Bartholin cyst. Then this what I wanted from you, that you can just remember this and we will do chanting for this. Cervix to body of uterus ratio. Cervix to body of uterus ratio. See, at birth and at menopause. At birth and at menopause, it is 1:1. Means cervix and body of uterus, they are equal size. So cervix to body of uterus at birth, at menopause, 1:1. At birth, at menopause, 1:1. So initially they are equal and finally after menopause also they are equal in length. Before puberty, cervix is longer. Before puberty, cervix is longer. So before puberty, cervix to body of uterus ratio 2:1. Before puberty, cervix to body of uterus ratio 2:1. Before puberty, cervix to body of uterus ratio 2:1. At puberty, things start changing because of hormonal influence. So at puberty, body of uterus is increasing. So at puberty, 1:2. Reproductive age, they are increasing further. So in reproductive age, cervix to body of uterus ratio is 1:3. Initially at birth they were equal. Finally after menopause also they will become equal. That is 1:1. Before puberty, cervix is longer. At puberty, things start reversing. Then pH of vagina. A very important MCQ here in pH of vagina is pH of vagina is most acidic during pregnancy. Very important MCQ. pH of vagina is most acidic during pregnancy. At birth, it will not be asked. It is acidic due to maternal hormones. At 3 places. Before puberty, it is 6 to 8 because no hormonal influence. Menopause, again it is 6 to 8 alkaline because no hormonal influence. Menstruation also it is 6 to 8. So at 3 places. Before puberty, menopause and menstruation, it is alkaline 6 to 8. Before puberty, 6 to 8. Menopause, 6 to 8. Menstruation, 6 to 8. Before puberty, 6 to 8. Menstruation, 6 to 8. Menopause, 6 to 8. And at puberty, it changes from alkaline to acidic. Reproductive age, it is 4.5. Reproductive age, it is 4.5. So important question, one important question out of this, pH of vagina is most acidic during pregnancy. Then another thing which I want to tell you, most common follicular cyst, most common ovarian functional cyst is follicular cyst. Most common ovarian functional cyst is follicular cyst. Second question, if you get any image like this in your exam, any image like this, and examiner is talking about something, pain in lower abdomen or some protuberance or abdomen is protuberance like anything, then without anything, without applying any brain, just mark the answer ovarian tumor. Just mark the answer ovarian tumor. That's all. Neat PG stuff. So I am telling you what you can remember. Risk factor, most common risk factor is more the ovulation, more is the risk of ovarian tumor. I highlighted just one. Then what you have to remember, most pathognomonic of ovarian malignancy are papillary projection. Papillary projections are most pathognomonic of ovarian malignancy. Then what you can remember is just histopathological findings, although this is an overlap with pathology, samoma bodies and all. Samoma body, serous epithelial tumor, samoma body. Histopathological findings, they are important. Serous epithelial tumor, samoma body. Mucinous epithelial tumor, honeycomb appearance. Mucinous epithelial tumor, honeycomb appearance. Brenner tumor, Walthardt cell nest, and coffee bean nuclei. Dermoid histopathological findings, hair, teeth, cartilage, and calcification. So if you see calcification and the X-ray film is given, that will be a dermoid. Dysgerminoma, large polygonal cells with lymphocytic infiltration. Large polygonal cells with lymphocytic infiltration. Endodermal sinus tumor, Schiller-Duval body. You just need to remember the name, if at all it is asked from you, if at all. Granulosa cell tumor, Gall-Exner bodies, Gall-Exner bodies. Hilus cell tumor, Rinke's crystal. Krukenberg tumor, we will just do tenting for it. Krukenberg tumor, signet ring appearance. Clear cell carcinoma, hobnail cells. Let's do some chanting for it. Come on. Serous epithelial tumor, samoma body. Serous epithelial tumor, samoma body. Serous epithelial tumor, samoma body. Mucinous epithelial, honeycomb. Mucinous epithelial, honeycomb. Serous epithelial, samoma body. Serous epithelial, samoma body. Speak out in your room. That's the best way. We will memorize them in 2 minutes only. Histopathological finding, tumor marker, just 2 minutes. Speak out. Serous epithelial tumor, samoma body. Serous epithelial tumor, samoma body. Mucinous epithelial, honeycomb. Mucinous epithelial, honeycomb. Brenner epithelial, Walthardt cell nest, coffee bean nuclei. Dermoid, hair, teeth, cartilage, calcification. Hair, teeth, cartilage, calcification. Dysgerminoma, large polygonal cells with lymphocytic infiltration. Endodermal sinus tumor, Schiller-Duval body. Endodermal sinus tumor, Schiller-Duval body. Granulosa cell tumor, Gall-Exner body. Hilus cell tumor, Rinke's crystal. Krukenberg tumor, signet ring appearance. Clear cell carcinoma, hobnail cell. Then tumor markers, serous epithelial, CA125. Mucinous epithelial carcinoembryonic antigen and CA19-9. Dysgerminoma, LDH and alkaline phosphatase. Choriocarcinoma is HCG. Embryonal cell carcinoma, HCG and alpha fetoprotein. Endodermal sinus tumor or yolk sac tumor, alpha fetoprotein and antitrypsin. Granulosa cell tumor, inhibin. That's all. So these are the tumor markers. Just in 1 minute, we will do some chanting. Serous epithelial, CA125. Serous epithelial, CA125. Mucinous epithelial, carcinoembryonic antigen, CA19-9. Dysgerminoma, LDH alkaline phosphatase. Dysgerminoma, LDH alkaline phosphatase. Choriocarcinoma, HCG. Embryonal cell carcinoma, HCG and alpha fetoprotein. Endodermal sinus tumor or yolk sac tumor, alpha fetoprotein and antitrypsin. Granulosa cell tumor, inhibin. CA vulva, just one thing, most common risk factor is HPV-16. Most common risk factor for CA vulva is HPV-16. Second, most common symptom in CA vulva, pruritus. Most common histopathological variety, squamous cell carcinoma. Most important prognostic factor, lymph node involvement. And sentinel lymph node is superficial inguinal lymph node. Although I have written DUB, we know the definition, irregular bleeding per vaginum without any organic pelvic pathology. Again, a neat PG stuff, but just in all-in-one also, I wrote Schroeder's disease. So Schroeder's disease is also called metropathia hemorrhagica, premenopausal DUB or metropathia hemorrhagica or Schroeder's disease. The only question asked here would be what is the histopathological finding is Swiss cheese endometrium, which is also called cystic glandular hyperplasia. So, Swiss cheese endometrium or cystic glandular hyperplasia is seen in metropathia hemorrhagica or Schroeder's disease, neat PG stuff. Types of hysterectomy, no one will ask you, although I have given you in PDF. Then COVID in pregnancy, I don't think they will ask, but you should know just one thing that COVID 19, although I have colored it, COVID 19 virus, COVID 19 virus is absent in vagina, breast, and amniotic fluid. So, risk of vertical transmission from mother to fetus is minimal. You should know it is absent in vagina, breast, and amniotic fluid. Then, second important question is most common time of transmission of infection in COVID postpartum period. And most common mode of transmission is droplet infection. Effect on fetus, no one will ask. If at all anyone is asking, answer to everything is a big no. No increased risk of abortion, no increased risk of teratogenicity, no increased risk of fetal infection, no increased risk of vertical transmission, no increased risk of IUGR. Then she can hold her newborn baby, skin to skin contact is allowed, and can share room with her newborn baby. That's all. So you can just go through tumor markers and histopathological findings and few highlighted things here. Wish you all the very best and now try to acclimatize your daily routine according to examination day. Try to do MCQs between 11 to, it tries to do MCQs between 9 a.m. to 11:30 a.m. and 2 p.m. to 4:30 p.m. And during the break time, what you will be doing? During the break time for 1 hour at least, particularly between 12 to 1 p.m. Try to practice quickly single liners, one liners, as you will be doing in examination hall, on examination day, outside examination hall. So please try to acclimatize yourself, wake up somewhere around 5 a.m. or 6 a.m. Go to sleep somewhere around 12 a.m. or 1 p.m. So, and try to have similar breakfast, similar lunch as you will be having during exam day. And all these are missed mock tests. All three mock tests you should give while sitting properly on a study table, wearing proper dress and shoes also, and try to have similar kind of breakfast in the morning and try to spend those hours during lunch break as you will be spending, as you will be doing in examination hall, so you can go for opening of all-in-one mist and one-liners quickly to scroll the pages as you will be doing there. So try to acclimatize in each and every way according to exam day now, because we are nearing exam day and you are feeling lot of anxiety. I know I get many messages. So see, be cool now. You are not able to memorize this, you are not able to memorize this, this is happening, that is happening. This is quite normal. This is indicating that you have really prepared well. With the response I got today, means I'm so happy, I'm so happy with the response I got today. With the response, see, all these messages means you have prepared very well. How well you are interacting, it means you are prepared. And you will have a good recall in examination hall. Only thing is you have to be cool during these 7 days also. If you feel nervous, if you feel over pressurized, just take your awareness to your breathing for 2 minutes only. Just see. You will feel relaxed. It's a long journey. It's a long journey of looking at your breathing from inspiration to, I am telling you to look at your inspiration to expiration. And the journey is starting from inspiration, then top of head to toes, everything. You are looking everything inside, all the nerves, all the vessels. That's a long journey, way beyond after your exam. Then we will discuss how meditations are done. That's a story after examination. We are connected forever, for lifetime. It's not only a student teacher relationship. You will be working, you will be doing internship, you will be doing PG. We are connected forever. So don't think anything. So just till your exam, 7 days, just see your inspiration and expiration for 2 minutes. Have good diet. Don't take much of the fried things. That's all. And when you are studying at home also, don't just lie down on a sofa or a bed. Try to, particularly between 9 to 11:30 and 2 to 4:30. Try to acclimatize yourself according to exam day. Don't will not take much of your time. Wish you all the very best from bottom of my heart. And 4 डालो 7 days just revise. कुछ याद नहीं हो रहा, just open the next register, open the next subject and start revising. इतना कुछ है रिवाइज करने के लिए, just revise. Bye bye, take care.